250 mL per hour, tatanggapin mo ay magugulat ka na, 2 oras pa lang lunod na si patient. Okay? So make sure na appropriate sa kilogram sa timbang ni patient ang pagbigay ng fluid resuscitation. Okay, another thing is you have to make sure that tawag nito, there is an adequate urine output. Kasi kapag walang adequate urine output, kagaya lang yung sa exam ninyo na ang intake niya is 1,500, ang urine output niya is 50 at wala pa rin sa inyo, sino naka-worry niyan? Ang winori nyo ang pulse rate, ang BP, ang saturation, hindi nyo man lang ni-worry ang output niya na 50, that is an indication na meron ng fluid overload si patient, kaya malunod yun. Okay? Buti na lang, nag-order na ng Lasix kaagad. So, make sure na meron talagang kaakibat na fluid output or urine output ang pag-monitor nyo. Okay? Next. Nutritional. Okay, usually during the acute stage talaga, yung nasa hospital, hindi pa natin siya muna ini-start ng pagkain. Kapag na-stabilize na si patient within 24 hours, 24 to 48 hours, ayan, mag-start na tayo. Well, it will be the doctor who is going to order that, pero you have to anticipate also na stable na si patient, wala pa namang order na pagkain. Itanong mo na pag rounds ni doctor, Doc, kailan tayo mag-start ng feeding kay patient? O, iyan. Kasi minsan, sometimes si doctor makakalimutin sa dami ng pasyente niya. Okay? So, pwede niya i-remind. Pero wag niyo siyang unahan. So, ibig sabihin nun, kapag sumasama kayo sa doktor, you have to be assertive, but at the same time, wag silang pangunahan. May mga doktor ma-pride talaga. Yabang ng nurse na to, akala mo, dami mong alam. Yung mga ganon. So, kailangan dandan. Pag yung tapos na siya magbisita and then tapos na siya mag-order, tignan mo yung order. Tapos kung wala pa nga ang pagkain, tapos yan nga, pwede mo ito, Doc, kailan tayo mag-start ng feeding kay patient? Ay, oo nga pala, buti na paalala mo. Sige, start natin yan mamaya. O, order na siya. Yung mga ganon. Huwag mo pangunahan kasi natagalit mo na yan. Okay, so enteral feedings are preferred than parenteral because of the infection vulnerability of this patient. So, kailangan enteral. Again, when you do the feeding, meron pa rin tayong mga nursing management doon. You have to make sure na yung NGT ay nasa site. So, meron tayong mga measures on how to check the NGT. I hope by this time, when you had your MS2, doon yun. Doon yun, paano pag-insert ng ECG, paano pag-remove ng ECG, NGT, paano pag-remove ng NGT, paano pag-check ng NGT. Doon yun sa MS2. I hope na nagkaroon na kayo na-encounter nyo na yan noon. Okay? Move. Nursing management, okay, so alam na natin yan. Basta alam nyo lang paano pag-measure, check nyo lahat-lahat ng variables. Monitor, it should be every 15 minutes because patient in the ICU, lagi-lagi yan monitor every 15 minutes. Kasi at any time, pwedeng bigla na lang magbago ang parameters ng hemodynamics niya. At the same time, ang pinaka-tool natin is the GCS. Okay? Move. Wala na? Okay, meron na. Napag-usapan na natin yan. Antibiotics, oxygen saturation, oxygen ventilation, na yan. Now, if patient needs to be ventilated, okay, meron siyang kailangan i-intubate siya. So, what are the nursing management kapag intubated ang patient? I hope na na-encounter nyo na yan sa MS1. Kasi MS1 din yan. Okay? Kasi dito sa MS3, management na lang and emergency or mga management na lang ng critical condition. Ibig sabihin, nandyan na lahat nakakabit ang contraption, monitoring at interpretation na lang ang gagawin kapag tayo ay nasa MS3. Dahil alam na natin ang mga nangyayari, so ito, kailangan bantayan natin maigi dahil ayaw natin gumrabe pa siya ng lalo. So I hope that you had this encountered in your MS1. Okay, next slide. Hemodynamic support, ayan na. This time, you can start giving the vasopressor. Okay? Sometimes, si inotropes at si vasopressor pwede ibigay ng sabay. Okay? And continues on hemodynamics monitoring. Kapag naka-pulmonary arterial catheter siya, take note of the pulmonary wedge pressure. Bakit ba kailangan? O, tignan nyo. Ano ba ang gustong mangyari? Bakit meron tayong pulmonary wedge pressure monitoring? Yung mga ganun bagay. Bakit kailangan i-monitor pa rin continuously ang MAP? Yung mga ganun, ang mga SBR. O, mga lumabas sa exam yan. Okay? And of course, infection control measures na which we discussed na kanina. Emotional support, this is a crisis intervention for the family. Particularly the family, if the patient is the breadwinner of the family, tas nasa ICU and they really do not know when and where and how. So, kumbaga, sobrang crisis talaga ang family. So, marami tayong mga intervention to pacify their anxiety. Part pa rin yan kasi holistic tayo. Okay? So, wala na. Okay, so ready na ba ang next? Next group? Thank you guys, mga reporter. Maglagay ako ng portal para dyan isubmit nyo sa BS ha. Mamaya maglagay ako ng portal. Sige na po. Okay, Colleen, ano yon?
Ma'am, sorry po. Ask ko lang po sana if tuloy pa po ba yung face-to-face later para makapag-prepare po. Kasi may magpapavaccine pa po, ma'am, and yung iba po is
Okay.
inaayos po yung requirements for INO po, ma'am.
Ewan ko kung babalik pa utak ko. Ay, nako. Natural, sige na. Hihingi pa kayo. Sige na, wala na, panalo na kayo. Sige, mag face-to-face tayo. Pero kailangan interactive kayo. Panalo kayo. Pero ano ang nakita ko sa inyo? Nurse na nga talaga kayo kasi proactive. Oy, alam niyo na, pagka-vaccine, masamang pakiramdam. Okay lang, kasi meron mga nag-vaccine, wala namang pakiramdam. Walang nararamdaman. Pero some kasi, nagre-respond sila na mahina, nilalagnat and things like that. So, okay naman. Payag naman ako mag-online. Pero dapat lahat kayo present, mga bruho-bruha kayo. Ha? Importante talaga ang subject na ito. Okay? Oh.
Okay po, ma'am. Thank you po.
O, sige na. O, sige na. Next na. Antay ko na lang ang ano, ha. Ikaw talaga. Pasimuno mo yun eh. O, sige na. Kaya pa kaya yan? Sige, continue lang natin hanggang saan tayo mag-stop and then continue natin kasi kailangan talaga natin matapos yun ngayon dahil sakop talaga lahat yan sa exam. Okay, Doops? So, waiting pa ako sa next group. Ano na ba ang next group? DIC? Okay, sige, DIC.
Wait lang po, ma'am. Nagpe-prepare pa po.
Okay, sige. Sisigaw na sana ako eh. Buti nagsalita ka. Sige, wait na lang ako.
Good morning, everyone. Kami ang Group 4. Ang topic 4 namin is disseminated intravascular coagulation. So, ang group members po namin, starting from our leader, Shane Tamil, Miss Sabrina Castillo, Miss Royce Ambat, Mark Joshua Mercado, Jen Calios, Erica Galestre, and ako po, More Charles Ray. So, next page po. So, ang aming didiscuss po is definition, assessment, diagnostic, clinical manifestation, etiology, pathophysiology, pharmacotherapy, care of management, medical, and nursing management. Next po. As for the definition, disseminated intravascular coagulation, commonly known as DIC, is a complex and critical medical condition. This is also a serious condition characterized by the abnormal and uncontrolled activation of the body's blood clotting system. The body's blood clotting system can also have serious consequences, such as small blood clots form throughout the body's blood vessel, while at the same time, the body's natural ability to control clotting is disrupted. DIC is often a secondary response to various underlying diseases and medical situations. DIC is typically not a primary disease, but rather a complication of underlying medical condition. Understanding DIC is crucial for healthcare professionals as early diagnosis and intervention are key to managing this condition effectively, which will be discussed by our group reporters.
So for the assessment po, since yung DIC nga is may underlying cause siya, so we need to know the medical history of our patient. If meron po ba siyang mga condition or triggers na pwede mag-lead sa DIC such as sepsis, trauma, cancer, or pregnancy-related complications. After that, pag nalaman na natin yung medical history ni patient, ngayon naman magpi-physical assessment tayo sa kanya para malaman natin or para tignan natin yung signs and symptoms na associated with DIC. So, una dito is yung petechia. Ito yung mga round spots na makikita natin sa katawan ni patient. It is either red or brown yung kulay niya. Possible reason nito is yung platelet dysfunction natin kasi nga nagkakaroon ng clotting and bleeding si patient sa katawan niya. And then ecchymosis, ito naman po yung nagli-leak yung blood ni patient sa blood vessels niya kaya nagkakaroon ng bruising. And then bleeding from mucous membranes and signs of organ dysfunction. And also, tignan din natin if yung level ba ng consciousness ni patient ay mataas or mababa kasi baka may clot na yung brain ni patient kaya onti lang yung oxygen na napunta sa brain niya. Then check po natin if may shortness of breath din si patient para makatulong sa atin if ma-determine natin yung DIC ba ay nag-o-occur na sa katawan ni patient. Then assess din po natin if may color changes sa katawan ni patient katulad ng sinabi ko kanina na mapapansin natin yung petechia and ecchymosis sa katawan ni patient. And also yung temperature changes sa mga extremities ni patient na magsasabi sa atin if may clot formation na ba sa katawan ni patient. And also, tulad sa sinabi sa sepsis, increased heart rate and decreased blood pressure ay mangyayari din dito sa DIC. Next slide po. So, for further diagnosis po ng DIC, imaging studies po ay ginagawa para malaman natin and ma-assess natin kung ano yung mga organs na may complication or damage. Pero depende naman po sa patient symptoms and clinical presentation yung gagawin natin sa patient natin. First is yung ultrasound. Maaaring gamitin natin to para ma-assess yung complication na associated with DIC or pwede rin po na ma-evaluate yung underlying condition na nagtitrigger sa DIC. For example po, sa mga cases ng DIC na caused by sepsis or infection, maaaring gamitin ang ultrasound po para ma-identify yung source ng infection and para ma-assess yung status ng internal organs. And lastly, para ma-monitor po nito kung mayroon bang associated complication gaya ng abscesses or organ dysfunction. Then yung CT scan naman po is hindi ito yung primary na ginagamit para ma-diagnose ang DIC, pero ginagamit ito para mag-evaluate ng complication or associated condition na pwedeng mag-arise from DIC. And then, echocardiogram po ay pwedeng gamitin sa mga specific na case associated sa DIC para ma-evaluate yung potential complication or para ma-assess yung impact ng DIC po sa cardiac function. And then, meron din pong ginawa ang ISTH or the International Society on Thrombosis and Homeostasis na scoring system po para ma-identify if may yung severity po ng DIC ng ating patient. So next slide po. Ayan, makikita po natin dito sa slide na to yung scoring system na ginawa po nila. And then kapag less than 5 po yung score, yung overall total score is wala pong DIC ang patient. Pero pag equal po siya and greater than 5, may DIC po si patient. So for the lab results po, next reporter.
So next po is yung laboratory results. So sa DIC, chine-check po natin yung CBC, specifically sa hemoglobin, hematocrit, and platelet count. So sa CBC, wait lang. So yung low platelet count is nag-i-indicate ng common finding ng DIC, and yung mga naka-red font po is yung normal value ng each test. And then next is yung coagulation profile. So elevated prothrombin time or yung PT and elevated APTT. So sa coagulation profile po includes measurement ng PT, PTT. So yung prolonged PT and PTT can indicate impaired clotting function, and the PTT ay ina-assess yung activity factors na nai-involve sa in-string pathway of coagulation cascade. So similar din po siya sa PT, ganon din po. So next is yung sa D-dimer. So elevated D-dimer level indicates yung presence ng fibrin degradation products and are suggestive sa ongoing fibrinolysis. which is madalas na nakikita sa DIC. And then next lab is yung FDP. So elevated FDP levels are a direct marker of fibrinolysis and can indicate ongoing clot breakdown. And then next po is peripheral blood smear. This may reveal yung presence ng cytocytes. Ito yung fragmented red blood cell which are a sign of microangiopathic hemolytic anemia na makikita din sa DIC. Next slide. So next is yung liver function test. So ina-assess dito yung liver dysfunction na nakakaapekto sa coagulation. First is yung ALT and AST. So elevated level ng ALT and AST can occur in DIC na nag-i-indicate ng damage or injury sa liver. So these enzymes are released into the bloodstream when liver are damaged. And then next is elevated level of bilirubin, particularly the direct conjugated bilirubin. So nakikita din ito sa DIC and this may be due to impaired liver function or cholestasis. Ito yung obstruction of bile flow resulting from involvement. And then next is ALP or alkaline phosphate. While not specific to DIC, pero yung elevated level ng ALP may occur in various liver disorders and they can be observed if yung liver is affected sa DIC. Another lab test is yung sa renal function test. Ito ay para ma-monitor yung kidney function. Kidney function as DIC can lead to kidney damage. So first is yung elevated result ng serum creatinine. Ano ba yan? Wait lang po So, yung elevated serum creatinine level may indicate ng kidney dysfunction or acute kidney injury, which can result from microvascular clots sa kidney or reduce renal blood flow sa mga severe cases ng DIC. Another po sa renal function test is yung BUN or BUN. So increased level ng BUN ay another sign ng potential kidney impairment sa DIC and as it reflects the accumulation of urea in the blood due to decreased kidney filtration. Another test po is sa ABG. So para ma-assess din dito yung oxygen and carbon dioxide level sa blood, as severe DIC can lead to impaired gas exchange. So first we have yung pH. So sa DIC, yung pH level may decrease due to metabolic acidosis and this can occur because of tissue hypoxia and accumulation of lactic acid and yung impairment of organ function. Another po is yung PaO2 or yung partial pressure of oxygen. DIC can lead to impaired gas exchange due to microvascular clots and tissue damage. As a result, yung PaO2 niya may be lower than normal, indicating hypoxemia. Then next is yung PaCO2 or yung partial pressure of carbon dioxide. So yung dito PaCO2 can vary but is often within or near normal range lang siya. So in some cases, maaaring nag-decrease if mayroong respiratory compensation for metabolic acidosis na nagre-result sa respiratory alkalosis. Next is yung HCO3 or yung bicarbonate. So sa DIC with metabolic acidosis, yung the bicarbonate levels may be lower than normal as the body tries to compensate for acidosis. So this reflects an attempt to buffer excess acid in the body. Next is yung oxygen saturation. So, yung changes naman sa DIC, sa oxygen saturation is maaaring lower than normal in some cases of of hypoxemia due to reduced oxygen delivery to tissues. Next slide. So, next po is yung clinical manifestation. First is yung bleeding symptoms. So, dito naka-include yung petechia. Ito yung small pinpoint red or purple spots sa my skin. Ito yung condition na nagka-characterize ng widespread activation ng coagulation cascade na nagli-lead sa formation ng small blood clots throughout the body's small blood vessels. Then next is yung purpura. Ito yung mas malaking patches sa skin, red or purple din yung discoloration na nag-i-indicate ng bleeding under the skin. Sa DIC, there is a widespread activation ng coagulation profile na pwedeng mag-lead sa formation ng small blood clots throughout the body's microvasculature. And then next is yung ecchymosis. Ito naman yung bruising that occurs spontaneously or with minimal trauma. And then next is yung oozing from venipuncture sites. So, ito ay nagre-result ng impaired ability of the blood to properly clot. So, it occurs because the clotting factors required for normal hemostasis are either consumed in the excessive clotting process or are not available in sufficient quantities. So, consequently, even minor trauma or injury such as the caused by a venipuncture needle can result in prolonged bleeding or oozing from the site. Then next, bleeding symptoms is yung mucosal bleeding. Due to compromised clotting mechanisms, leading to decreased ability to control bleeding from delicate mucosal surface. So, yung depletion ng blood factors necessary for normal hemostasis results in an increased tendency to bleed from this area. So, yung mga patient na may DIC may present with symptoms such as bleeding gums, epistaxis or yung nosebleeds, hematemesis, vomiting of blood or melena, dark taristors due to GI bleeding. Another manifestation po is yung clotting symptoms. So, dito nakapaloob yung DVT or yung pulmonary embolism. So, blood clots in the deep veins of the legs or clots that travel to the lungs. So, another one is yung skin ischemia or necrosis. So, gangrene-like skin changes due to microvascular clot. So, next is organ dysfunction. So, clotting in small blood vessels can lead to organ damage with the symptoms of specific affected organ. For example, ito ngayon kidney dysfunction, lung dysfunction, liver dysfunction, and neurological symptoms. So, for kidney dysfunction, dito yung decreased urine output or dark and blood urine. So, for lung dysfunction, yung respiratory distress, chest pain, and coughing fit blood. Sa Liver dysfunction naman is yung jaundice, abdominal pain, and altered mental status. And lastly, sa neurological symptoms, dito yung headache, confusion, or focal neurological deficit. Another manifestation po is shock and hypertension. So, sa shock, particularly ay septic shock, ay pwede maging factor for the development of DIC. Kapag yung body is unable para control yung system ng inflammatory response during an infection, ay maaaring mag-lead sa cascade of events that ultimately results in shock. This can manifest low blood pressure, inadequate sugar perfusion, and organ dysfunction. And yung hypertension naman or your low blood pressure can occur in the context of DIC due to several reasons gaya ng loss of intravascular volume, vasodilation, impaired cardiac function. And then next is respiratory diseases. So, this can result naman from flattening in the lungs, small blood vessels, or bleeding into the lung tissue. Another manifestation is renal impairment. So, the IC can lead to acute kidney injury, decreased urine output, and elevated serum creatinine level. Another manifestation is neurological symptoms. So, alternative sa lahat ng confusion neurological disease may or if mayroong impaired blood flow to the brain. So, complications such as ischemic stroke, hemorrhagic stroke, and other neurological diseases can arise as a result of the disruption of normal blood flow and your formation of the blood clots sa cerebral vasculature. And then last is yung hypothermia. So, patient with IIC may experience a drop in body temperature. So, hypothermia is not typically considered na symptoms, pero this may occur as a result of overall systemic effect and complications associated sa condition. Next slide.
So for urology naman po, disseminated intravascular coagulation or DIC is usually by inflammation and affection, injury, or illness. So as I said earlier nga, yung DIC is a rare condition na nagkukos ng abnormal blood clotting throughout the body's blood vessels. So nag-develop siya kapag yung isang tao is merong infection or injury na na-apekto yung body's normal blood clotting process. So as estimated, yung DIC kasi is present in 1% sa mga hospitalized patient. So yung DIC does not itself a specific illness, rather isa siyang complication or effect dun sa progression ng other illnesses. So ayun nga, it is always secondary to underlying disorder and associated with a number of clinical conditions generally involved in the activation of systemic inflammations and such conditions na nababanggit ko. So, merong multiple conditions na nag-lead para ma-develop yung disseminated intravascular coagulation. It is either through systemic inflammatory response o yung SIRS o yung pag-release ng procoagulants dun sa bloodstream. So, yung pathological processes ng DIC, estimated na nag-occur up to 30% to 50% ng mga cases na merong severe sepsis, which is yung most common cause ng DIC. And yung other cause nga ng sepsis, katulad ng mga parasites yan, pwede yung mag-lead to DIC. So, up to 20% naman mga patient na merong metastasis adenocarcinoma or lymphoproliferative disease, and 1% to 5% ng mga patient na merong chronic disease katulad ng mga solid tumors or yung mga aortic aneurysms, yan also suffers from DIC. Next, yung mga obstetrical complications katulad ng mga placental abruption, hemolysis, elevated liver enzymes, low platelet count, and yung mga amniotic fluid embolisms has also been known to lead DIC. And yun nga, mga other causes ng DIC katulad ng trauma, pancreatitis, malignancy, snake bites, liver disease, transplant rejection, and transfusion reaction. O yung tinatawag natin merong severe immune reaction. Ito yung kapag yung katawan natin is nag-overreact because of failed blood transfusion, rejection ng mga organ transplant, or yung mga toxins katulad ng mga snake venom. And yun, also kasali dito yung merong major damage sa organs or tissue na nagkakause by cirrhosis sa liver, pancreatitis, severe injury, burns, or major surgery. So, merong 15.5% ng mga cases na DIC is nalilink dun sa complications occurring after surgery. Next.
Okay, so ayan, good morning. So at this point, we will discuss the pathophysiology. So as you can see on the screen, this is a pathophysiology adapted from the Calgary Guide. Pero medyo complicated siya since nakasama rin kasi dito yung mga sepsis and other hematologic malignancies that could also lead to DIC. So to better understand, I divided it into 10 steps or 10 parts yung pathophysiology. So next slide. Wait lang po, umiihi daw si Joshua.
Oo,
Titigil na lang muna natin.
sabi ko na nga ba eh.
Akala niya ata discuss ko ng buo.
Sige.
Wait lang, mama. Hindi ko kasi inaral ito eh. Ayan. So ito easier for better understanding lang. So ayun nga, as what was mentioned earlier, DIC does not just happen on its own. So laging may nagko-cause. There is always something that cause DIC. So lagi tayong merong triggering factor. And DIC often begins as a response to an underlying medical condition such as yung na-discuss sa etiology like yung severe infection, sepsis, trauma, and the likes. So, etong trigger na to could be a systemic inflammation, tissue damage, or release ng procoagulant substances. So, yun yung initial trigger natin. So, hindi tayo magkakaroon ng DIC kung walang initial trigger. Now, since meron nga underlying condition, itong underlying condition na to or itong trigger na to will lead sa endothelial cell injury. So if we will go back to our anatomy, alam natin na yung endothelial cells natin, it lines our blood vessels and siya yung isa sa mga responsible sa pag-maintain ng normal blood flow and pag-prevent ng clot formation. Yung endothelial cells din kasi natin, isa sila sa responsible sa vasoconstriction and vasodilation ng blood vessels natin. Now, kapag nagkaroon ng damage or nagkaroon ng injury sa endothelial cells natin, that will lead to the exposure ng collagen and tissue factor, and that will trigger the coagulation cascade. So, yung coagulation cascade natin, yun yung steps or processes na nangyayari during the formation ng blood clot after ng injury. So, nagkakaroon ng activation ng cascade of proteins called clotting factors. So, ayun, kung matatandaan nyo rin sa MS natin before, sa hematology, di ba, nasabi sa atin na sa blood clot, merong iba't ibang factors. So, if I'm not mistaken, parang 14 yun or 13, tapos may mga sub-factors pa. So, ayun, isa doon yung tissue factor natin. So, kapag may injury, pag may endothelial cell injury, magre-release yun ng tissue factor. And then next, now, again, kapag na-injure nga yung endothelial cells, mag-release siya ng tissue factor. Yung tissue factor, again, isa yun sa mga pro-coagulation factors natin sa blood. So, once mag-release yung endothelial cell natin ng tissue factor, mag-initiate yung coagulation cascade. And once na mag-release yun, once na ma-release yung tissue factor natin, that will lead to the formation ng fibrin. Yung fibrin, yun yung protein sa blood natin that is responsible for clot formation. And as a result, magkakaroon tayo ng overproduction ng thrombin. Yung thrombin naman, isa siyang key enzyme ng coagulation cascade. And yung thrombin na yun, i-convert niya yung soluble fibrinogen into insoluble fibrin, which forms the basis of blood clots. So once na-activate yung coagulation cascade, magkakaroon tayo ng formation ng thrombin, and yung thrombin, i-convert niya yung fibrinogen into fibrin. Ayun. So magkakaroon tayo ng blood clot. So yung too much fibrin na yon caused by the overproduction ng thrombin will lead sa pag-form ng small blood clots or microthrombi sa katawan. These microclots can obstruct or mapipigilan niya yung blood flow, and that will lead to the reduced oxygen and nutrient supply sa organs and tissues ng katawan gawa nga ng clot. So hindi maka-travel yung blood dahil sa clot. That's why magkakaroon tayo ng reduced oxygen, and that explains yung mga clinical manifestations kanina that are related to the respiratory system. Ayun. So, dun na tayo sa consumption of platelets. So, balik po. So, once na magkaroon tayo ng small clots or yung microthrombi, kakainin nun or i-consume niya yung platelets and yung other clotting factors natin sa blood. Kaya magkakaroon tayo ng thrombocytopenia. Kanina nasabi na parang decreased yung platelets. So, that's the reason. Nagkakaroon kasi tayo ng microthrombi, and yun, i-consume niya yung platelets and yung ibang clotting factors. And because of that, magkakaroon din tayo ng depletion or yung pagkaubos ng coagulation factors natin. With this, mahihirapan yung katawan natin or yung blood na mag-develop ng new clots kapag kailangan mag-develop to control the bleeding. Kasi nga, less yung platelets and yung clotting factors natin. And because of that, because of the depletion ng clotting factors natin, nagkakaroon ngayon ng bleeding tendency. Also, yung microthrombi kasi or yung clots nga, nadadamage na yung blood vessels, and that can cause bleeding sa iba't ibang sites ng katawan natin. Kaya, magkakaroon tayo ng bleeding tendency, mas madali tayong duduguin, masusugatan. Ganun. Next. So, dahil sa clot formation natin, nag-initiate or natitrigger yung fibrolysis sa katawan natin. Yung fibrolysis is yung process ng pag-breakdown ng fibrin clots. So, ito yung reason kung bakit may elevated levels ng FDP, D-dimers, gano'n, sa bloodstream natin. Kasi na-activate yung, or nag-breakdown yung mga fibrin clots natin. Kaya tumataas, nag-elevate yung mga coagulation parameters sa blood natin kapag nag-test tayo, tapos may DIC yung patient. Now, dahil sa clotting or dun sa thrombocytopenia, sa pagkaubos ng clotting factors and sa bleeding, maglilid to sa multi-organ dysfunction. So, affected organs, nasabi na ata kanina, affected organs may include the kidneys, liver, lungs, and brain, among others. Kasi, as we all know, blood, it travels all around our body. So, lahat ng organs natin, dumadaloy talaga yung dugo. So, kapag nagkaroon ng problema sa blood, sa pag-transport, sa pag-travel ng blood, of course, maapektuhan din yung organ system natin. So, yung underlying condition na nag-trigger sa DIC kanina, that will lead to systemic inflammation. And once nagkaroon ng inflammation, mas lalong lalala yung coagulation and bleeding. So, yun yung pinaka-thought ng process or ng pathophysiology ng DIC. So, kung walang triggering factor, wala nang mangyayari. Pero once na nagkaroon ng triggering factor, madadamage or may injury yung endothelial cells natin, and doon na magsa-start yung mga reactions, chemical reactions sa blood natin, that will lead to organ dysfunction. And once na nagkaroon tayo ng organ dysfunction, yung triggering factor natin, mas lalo siyang parang lalala. kasi nga na-trigger siya nung DIC. Ayan po. Thank you.
Okay, very good. Wala akong masabi. Continue.
So let's
Kaya-
move to
Oh.
the pharmacotherapy of DIC. So pharmacotherapy for disseminated intravascular coagulation or DIC primarily focuses on addressing the underlying cause of DIC and managing the coagulation abnormalities. So the specific treatment approach can vary based on the severity of the DIC and the underlying condition. So treatment of underlying condition. So, ito yung most crucial aspect of DIC management. Um, dito, nag-a-address and nagtitreat ng underlying cause. So, yung mga underlying condition ay isa sa medical condition or disease na nag-i-interfere sa daily lives and activities na nagre-require ng continuous medical attention or medical care na naglalast for more than a year. So, the underlying condition that cause DIC should be identified and treated as the main priority. So, in short, primary focus should be the diagnosis and treatment. So, ang key component ng management of either acute or chronic DIC is yung treatment ng underlying condition. So, i-avoid natin yung treatment, ng pagde-delay ng treatment for serious condition like yung shock, sepsis, and obstetrical complications. And this may include antibiotics for sepsis, surgery for trauma, chemotherapy for malignancies, or intervention for obstetric complications. So, successful management of underlying condition can often lead to resolution of the DIC. So, for blood products naman po, tawagin na lang natin siya na replacement therapy. So, this treatment aimed at making up a deficit of a substance na pwedeng hormone, I mean, making up deficit of a substance normally present in our body. So, ito yung therapy that involves supply of a substance na pwedeng hormone or nutrient na nagkukulang or nawawala sa body natin. So, kailangan natin ng blood products. So, yung blood products are frequently used to correct coagulation abnormalities associated with DIC. So, this includes platelet transfusions, FFP, or yung fresh frozen plasma, and also yung cryoprecipitate. So, for platelet transfusions, this is to address thrombocytopenia or yung low platelet count. So, para ma-keep yung platelet count, kailangan natin ma-utilize yung platelet transfusion. So, for fresh frozen plasma naman, this is to provide clotting factors and can help correct prolonged PT or yung photothrombin time and yung APPT or yung activated partial thromboplastin time. So, since DIC to, may coagulation factor deficiency at ito ay nagre-require ng replacement with FFP or yung tinatawag na fresh frozen plasma. So, for the last one is cryoprecipitate. So, it contains fibrinogen and other clotting factors and used when fibrinogen levels are typically low. So, unahin ko na yung anticoagulants bago yung fibrinolytic inhibitor. So, for anticoagulants, sunod, anticoagulant is used for anticoagulants in DIC is controversial and varies depending on the clinical scenario. So, heparin or low molecular weight heparin may be considered in selected patients to prevent further clot formation. So, this is typically reserved for patients with predominantly thrombotic DIC rather than primarily hemorrhagic DIC. So, we are aware that the heparin is anticoagulant na nagpe-prevent ng blood clots or nagkikip ng existing clot from getting worse. So people often receive heparin through an IV during a hospital stay, pero pwede din siya inject sa balat. Pero so people take heparin for different lengths of time depende sa kung bakit nila kailangan yung heparin. So yung heparin mabilis siya gumagana pero mabilis din nawawala yung effect niya. So attention or take note, yung heparin therapy must be used in combination with replacement therapy. Katulad ng mga nasabi ko kanina na fresh frozen plasma, platelet transfusion, and yung cryoprecipitate. So bakit nga ba? Kasi it can lead to severe bleeding. Next, for fibrinolytic inhibitors, in some cases, anti-fibrinolytic medications like tranexamic acid or aminocapric acid may be used in inhibit the breakdown of blood clots. So these are typically considered when bleeding is a major concern. So those two drugs kailangan i-add para ma-decrease yung rate of fibrosis, para ma-raise yung fibrinogen level, and ma-control yung bleeding. So attention ulit, yung aminocaproic acid can never be used without the heparin in the IC. Bakit? Because of the risk of thrombosis. Next is protease inhibitor. So antithrombin 3 concentrates may be administered in specific cases where the antithrombin 3 levels are severely depleted. So antithrombin 3 is natural anticoagulant in the body and supplementing and it can help control coagulation. So yun nga, ang antithrombin 3, ito ay isang protein daw sa blood that blocks abnormal blood clots from forming na nakaka-help sa body to keep health balance between bleeding and clotting. And for the supportive care, supportive measures are essential and may include providing oxygen, mechanical ventilator in severe cases. And also hemodynamic support with fluids or vasopressors for those in shock. Next, for fluid and electrolyte management. So, ang pag-maintain ng proper fluid balance and electrolytes level ay importante, especially in cases of the kidney dysfunction. And lastly, for the pain management. So, yung mga patient with DIC, pwede sila maka-experience ng pain from various sources such as yung ischemic skin changes, surgery, or underlying conditions. So, yung adequate pain management is kailangan na kailangan.
Okay, tapos na ang pharmacotherapy?
Yes po.
Okay, Dux. Ano pa ang next?
For the nursing and medical management naman po.
Wait lang ga. Medical and nursing management na lang, wala na?
Wala na po. Last na po.
Sige. Continue. Sige.
So for continuous assessment, monitoring vital signs including blood pressure, heart rate, respiratory rate, and temperature. And then frequent assessment of oxygen saturation and respiratory status. Then assess for signs of bleeding including petechia, ecchymosis, gum bleeding, melena, and hematuria. Then evaluate the patient level of consciousness and neurological status. Then for hemodynamic monitoring, in severe cases of DIC, patient may require continuous hemodynamic monitoring including central venous pressure or CVP and arterial blood pressure. Then for coagulation parameters, monitor coagulation parameters including platelet counts, prothrombin time, activated partial thromboplastin time, and fibrinogen levels and D-dimer levels. Then for fluid and electrolyte management, assess and maintain proper fluid balance, and monitor and manage electrolyte levels, especially in patients with kidney dysfunction. And for transfusion management, administer blood product as ordered, such as platelets, fresh frozen plasma. Then monitor for signs of transfusion reaction and ensure that blood products are administered according to hospital policies and guidelines. Then for pain management, provide appropriate pain management for patients who experience pain due to ischemic skin changes, surgical intervention, or other causes. Then respiratory support, monitor respiratory status and provide oxygen therapy or mechanical ventilation as needed for respiratory distress. Then wound care, care for wounds and skin lesions, providing wound dressing and keeping an eye out for sign of infection. Neurological care, maintain neurological assessment for patients who may experience confusion or neurological deficit due to organ involvement. Then for patient and family education, educate the patient and their family about the condition, the importance of adherence to treatment plans, and sign of complication or deterioration. Psychosocial support provide emotional support and reassurance to the patient and their family during this challenging time. Then for infection control, maintain strict infection control practices to reduce the risk of secondary infections, particularly in cases where the underlying cause is sepsis. Then for medication administration, administer medication as ordered, including anticoagulants and pain medications. For collaboration and communication, collaborate with the healthcare team, including physicians, specialists, and other healthcare professionals to ensure a comprehensive approach to care. Then communicate changes in the patient's condition or response to treatment properly. Then documentation, thorough and accurate documentation of assessment, intervention, and the patient response to treatment is essential. And that's it po. Thank you.
Okay. Uy, umabot ng 11:59, sakto-sakto. O sige, mamaya na tayo mamaya na ako isa-isang slide ha. Kain muna at gutom na si Lola. Okay, o break time muna tayo. Balik tayo ng 1:00. Bye!
Thank you po.
Okay, thanks, bye. nakitang sepsis na where the blood pressure drops, the MAP drops and things like that, kinukuha na rin natin, ini-evaluate na rin natin ang mga blood markers para sa DIC. Para kung meron man, maagapan na kaagad. Okay? So, ang mga basis natin is the CC, the coagulation profile, the D-dimer, the fibrin degradation products, and all this nakalista dito. Okay? So, ang mga importanteng bagay lang talaga na kailangan nyo tignan is kapag mataas ang level ng PT and APTT, expect nyo na ito ay precursor sa bleeding. And even if fibrinogen, nakita nyo, imbes na pataas ang baba, ibig sabihin lang ito, pwede talaga siya magkaroon ng bleeding. Now, bakit increase ang D-dimer? Ano bang indication ng D-dimer? Si D-dimer, hindi lang para sa DIC, pwede din siya sa mga cancer, sa mga pregnant, yung mga ganyan. Kasi itong result na ito, kapag mataas, ibig sabihin, it gives you a picture or it gives you a result or indication na merong presence of clotting or clot formation sa katawan. Kaya kapag mataas ang D-dimer, ibig sabihin may presence of clot, hindi natin alam saan or ano, so kailangan talaga natin gawa ng paraan. And even the fibrin. Now, fibrin is different from the FDP. Kasi si FDP, ito yun para mag-breakdown ang fibrin. Okay? So, kapag mataas to, ibig sabihin nun, candidate talaga si blood for bleeding. Okay? And then yung blood smear, walang problema ang blood smear. Isa sa mga isa sa mga example ng blood smearing is yung bleeding time, wherein susugatan ka, tapos, meron silang tool kung paano or ilang minutes talaga hanggang sa mag-stop yung bleeding. Parang ano siya, parang Oslo paper lang siya na naka-form na parang relo, parang bilog. Okay, so kunyari sinugatan ka ng maliit, yung kagaya ng lancet ng ng glucometer. So susugatan 'yan. Tapos hayaan niya lalabas yung dugo. Tapos i-blot niya lang 'yan doon sa papel. Tapos continuous yan ng paglabas ng kasi sugat yan di ba? Continuous ang paglabas. So i-blot na rin yung papel hanggang sa matapos or mahinto na yung paglabas ng dugo. So kinakount yan kung ilang minutes talaga. So kaya kung example lang yan is yung bleeding time is kung mahaba, ibig sabihin expect mo. Isa din yan sa isa din yan sa factor na masasabi natin, naku, delikado na papuntang DIC na to. Okay? So next, punta tayo sa laboratory. Meron yan ba? Meron pa yung sa mga liver chuchu. Next slide yata yun. Ayun. So si liver function. Okay. So expect natin, kapag elevated ito, it is indicative na waki na ang liver cells. Ibig sabihin ito, meron ng problema sa liver cells. Hindi na maigi or maayos ang pagpa-function. So what is in the indication if there is elevated bilirubin? So alam natin, ano ba ang ibig sabihin ng ano? Ano ba ang role ni bilirubin? Naalala nyo? Uy, andyan ba kayo? Andyan kayo? Erica, Kim, Jeneline, Christine, Ronalie, Chelsea, Melidia, Daniel, Christine, Kisha, Chuchu, sino pa? Naalala nyo?
Ma'am, yung bilirubin po ba yung mataas na bilirubin levels, result po ng mga liver disease or any problem sa liver?
Yes, pero ano ang role niya? talagang meron tayong bilirubin at check din natin yan. Now, sige, sabihin ko na lang yan. Yes, result siya ng liver problem kaya nagkakaroon tayo ng hyperbilirubinemia. Okay, but before having bilirubinemia, alamin muna natin, ano ba si bilirubin? Siya yung Erica, sige.
Yun po ba yung nagbe-breakdown po ng old red blood cells?
Nagbe-breakdown ng old red blood cells to lead to apoptosis. Okay? But hindi talaga siya kasi siya lang talaga ang nagbabahay sa mga apoptotic cells. Okay? So, meron tayong dalawang klaseng bilirubin. Okay? We have the conjugated and unconjugated bilirubin. Okay? So, ano ba yung ibig sabihin? Pag sinabing hyperbilirubinemia si patient, sometimes the doctor, hindi pa yan kontento sa ganyan. Sasabihin ni doctor, can you please ask to check the conjugated and unconjugated kung ilan sa yung dalawang yan. Okay, so yun yung hinihingi ni doktor. Okay, kapag kasi sinabi natin na na conjugated, ibig sabihin, another term for this is the direct bilirubin. Okay? So ano naman ang ano naman itong direct bilirubin? So ito ay mga na to, yung na dumaan na sa conjugation. Kumbaga, dumaan na siya sa liver for metabolism and ready na siya for excretion. It's either by ihi or by pupo. Okay? So makita niyo ang ihi natin parang almost parang yellow amber. Tingnan niyo yung pupo natin parang light brown chuchu, di ba? So ayan. Kasi conjugated na sila, pwede na. Now ano naman yung isa? Yung isa, di ba sabi natin dalawang klase yan. Isa si indirect bilirubin or yung sinasabi natin unconjugated. So for this bilirubin to be conjugated, it has to pass through the liver. Pero hindi sila basta-basta lang, kailangan mag-bind muna sila sa certain kind of protein. Okay? Para pag mag-bind sila sa certain kind of protein, pwede na sila sumama papunta sa liver para mag-convert into conjugated or para mag-conjugate na. Okay? Now, kung for example, marami tayong level of unconjugated bilirubin, delikado yan. Toxic level yan. Okay? Usually sa patient, makikita mo yellowish na kasi ang taas talaga ng ng unconjugated bilirubin sa bloodstream. Okay? What if mataas ang direct bili? Walang problema, direct bili naman tapos na dumaan na sa liver yan. Ibig sabihin ready na yan to wiwi and popo. Ma-excrete na yan. Pero kapag mataas ang indirect bilirubin, toxic ito sa mga cells, toxic sa lahat, and this can even cause cellular damage. Okay? So, kailangan talaga i-conjugate. Paano hindi na niya ma-conjugate? Kasi sira na, waki na si liver, pati mga ALT, AST, sira na. Mataas na. Kaya nakikita nyo, what do you call this? Yellowish patient. Same is true with patient with hepatitis C, last part or end stage, and hepatitis B that can lead to cancer. Yellowish na sila kasi hindi na nagpa-function ang mga liver. So mas marami silang unconjugated bilirubin. Pero kapag hindi pa obvious ang yellowish discoloration ng skin and then nakita nila na hyperbilirubinemic ang isang pasyente, kailangan talaga i-identify alin ang sa dalawa ang mas mataas, ang direct or ang indirect. Okay? So, gets nyo na yan? Next. Si renal function test, walang problema. Alam nyo na ito. Okay? Now, again, mataas si creatinine. Ibig sabihin, hindi na nakakapag-filter maigi si kidney or si glomerulus. The same way as si BUN. But if, for example, ito ay makita natin na the serum creatinine and BUN ratio is mataas, ayan na. Tapos makita mo na ang pasyente is yung tawag dito, itchy, ma-itchy yung skin, tapos matamlay and things like that. Ayun. Pwedeng magkaroon ng acute renal failure si patient, or kung ito ba naman ay nasa DIC stage na, wala na. Okay? Kahit anong magagawa natin, pero dysfunction na kasi. Going to mods na to. Okay? Going to mods and downward spiral na. Sa ABG, wala nang problema because you know how to interpret naman, di ba? Alam nyo na yan, nakuha nyo na yan sa, ano ba to? MS1. Sa MS1 ito eh. But you really have to take note of the pH, the bicarb, and the PaO2 and PCO2. Not necessarily the saturation. Pero nandyan si saturation is just to add kung ano ba, kung respiratory ba yan o hindi. Kapag waki si saturation plus si, what do you call this, si PCO2, ayan, delikado kasi it can be respiratory. Kapag waki si bicarb and PaO2, ayan, metabolic. Okay? Si pH, masasabi lang na sa atin kung acidosis sila or alkalotic. Okay, so move. Next topic. Next slide. Dito, meron ba akong nakita dito? Wala. Okay, wait lang. Dito sa clotting symptoms. Now, ang sabi natin, clotting symptoms is the DVT, and then ischemia sa skin or necrosis, and then organ dysfunction. Now, pag ganyan lang, masasabi mo, hindi mo masabi, ay, may ano yan, may clotting problem yan, ganun-ganon. But, along with the manifestations of the kidney dysfunction, lung, liver, and neurological dysfunction, plus yung mga petechiae and embolism and DVT, check nyo ang D-dimer. Kapag mataas ang D-dimer, ayun. Ibig sabihin may clotting formation ang loob ng katawan ni patient. Okay? Okay, next slide. Etiology, okay na natin yan, pero take note, kaya nga alam natin na ang mga buntis, delikado din talaga kapag ito ay hindi na ma-manage ng maigi. Alam niyo ba ako, isa akong biktima, hindi naman biktima, pero yung unang baby ko was abruptio placenta. And abruptio placenta can lead to DIC. Oo, delikado. Hindi ko pa alam yon kasi duty ako. Ang duty ko kasi every morning, tapos pag naghahabol ako ng bus, tumatakbo ako kahit buntis. Kasi may mga ano kami, may terminal yung ano namin, accommodation namin ang layo. Tapos maghintay kami ng bus. The same way, pag galing sa hospital, punta kami sa motor pool para doon sasakay, ihatid sa bahay. So, laging ganun. Tapos, yung lifting, pero nagli-lift ako kahit buntis, pero hindi ko nararamdaman yung bawal and things like that. Wala, nag-high heel pa ako. And then, one day lang talaga, naramdaman ko na ang sakit talaga ng tiyan ko. Tapos, parang humihilab. Hindi ko pa alam yun kasi first time eh. Hindi ko alam na nagle-labor ako. 7 months, hindi ako naniniwala. 7 months pa lang. Tapos, nung hindi ko na talaga, parang mayat-maya sumasakit, mayat-maya sumasakit. Buti na lang at 7 months, naisipan ng asawa ko bumili ng kotse. First kotse namin yon nandun sa Saudi. And then, para mag-celebrate yon, inimbita namin yung best friend ko na head nurse namin plus yung asawa niya. Doon sila nag-dinner sa amin. Pero hindi ako sumali sa kanila. Sila lang tatlo kumakain kasi ako nasa loob ng kwarto kasi sobra talaga sakit ng tiyan ko. Tapos, paggabi ng paggabi, nawawala na ako ng lakas. Tapos yung huli, sinabi ko sa asawa ko, ihatid ako sa CR kasi naiihi ako. Nung umihi ako, dugo yung lumabas. So, sabi ng kaibigan ko, yung head nurse namin, sabi niya, ay naku, dalhin na natin sa ospital yan. Buti na lang, may kotse na. O, nakagamit kami ng kotse. Ito sinatid na sa ospital. Tapos, Yung ramdam ko, masakit lang, wala akong ibang nararamdaman. Nung chinek ang blood pressure ko, ang taas. Tapos, narinig ko lang yung doktor sinabi sa kanila, where is the husband? Tapos yung sabi, okay, your wife is in emergency situation. She needs immediate cesarean section. Yung ganun. So, hindi pa namin alam yun kung ano, kasi ano, pero narinig ko sinasabi, the placenta is almost out. If we delay the operation in 1 hour, the baby will not receive the necessary oxygen and nutrients anymore. Kasi ano na dislodge na yung placenta, kunti na lang talaga humahawak sa endometrium. So, alam mo, yung hospital na yun na saan kami pumunta, hindi pa ako pwedeng magpa-hospital doon sa saan ako nagtatrabaho kasi bawal. Bawal kasi doon ang may asawa. So, sa labas kami sa government hospital kami pumunta. So, yung hospital na yun, sa area na yun, iisa lang ang operating room. At saka meron silang elective CS. Ibig sabihin nun, yung elective, yung nakaschedule na CS. So, dinala na doon ang pasyente. Ibig sabihin, isasalang na pinaprep na siya para bibigyan na siya ng anesthesia. Tamang-tama talaga yung result ng ultrasound ng yung timing to. Pinahinto yung nakasalang doon para ilagay muna ako. Kasi, emergency talaga. So, afterwards, after CS, natapos na, ayun, kinuwento nila sa akin na yung kabilang kwarto ko is dapat siya ang mauna pero inano muna nila iset aside para ako dahil emergency. Wala na akong hindi ko na alam yan, hindi ko na alam yung kwento-kwento nila. So after that, punta ako sa kanya para para mag-thank you. And one thing I have observed post-operatively kasi very curious ako. So, alam ko, in 2 hours time, kailangan gumalaw na ako after operation. So, nag-turn na ako, ganyan. Pero naging curious ako. Sabi ko, sige nga, hindi ako gagalaw. Tignan ko nga anong nararamdaman ng mga pasyente kapag hindi tiniturn. So, sinadya ko talaga yun, hindi tiniturn at one position. Sobrang ngalay pala talaga. So, doon ko naintindihan na kailangan talaga galaw-galawin din ang mga pasyente natin sa room. Tapos, di ba, pag post-operatively, nag-chill tayo, kasi ramdam ko yung lamig, sobrang lamig, kahit naka-cover ako ng makapal na kumot, sobrang lamig. Pero nung hinawakan ako ng nurse na mainit ang kamay, doon ko naramdaman yung comfort na parang nawala yung init ko kasi ang init ng palad niya. Kaya ngayon, alam mo, pag yung nag-duty kami sa DR dyan sa EACMED, kapag meron talaga nag-chill, hinahawakan ko talaga ang kamay kasi doon lang talaga nila mararamdaman yung tunay na init talaga. So gawin nyo rin yan kasi isa din yan sa mga bagay na kailangan ng mga pasyente na nakahiga, na nag-chill from post-anesthesia. Okay, so yan lang experience ko. Okay, so far naman itong mga etiology, tama naman talaga yan. Move tayo sa next slide. Okay, wala na akong masabi dito sa explanation ni Shane kasi isa-isa na-explain niya dito at it's very clear naman the same way as yung group kanina. So move tayo dyan. Move. Sige. Okay, dito. Now, what I just wanted you to know about the blood products, usually talaga kapag mababa ang platelets, binibigyan natin ng platelets. Okay? Now, these platelets, hindi ito isang malaking bag. Parang oil siya na maliit, kunti lang, siguro mga mga 50 to 100 cc lang sa bag. Once it is given to you, immediately it should be transfused na pass drip. Okay? Hindi ito kagaya ng blood na unti-unti. At saka the same way yung platelet kapag ito ay ina-administer, make sure muna patent yung kasi napaka-importante itong dugo nito. Kailangan patent yung IV line mo. Kung hindi patent, kailangan mo talaga lagyan ng panibagong 18 gauge na IV line. Okay? At matatapos lang to within 20 minutes. So, walang problema. The same way as the fresh frozen plasma. Pagdating yan sa'yo, frozen pa. So, you let it to thaw. Palambutin mo yan. Matigas pa yan pagdating sa'yo. Pero, in an advanced hospital, sa mga technology, meron silang technique, meron silang machine para paano i-defrost yung fresh frozen plasma. At kahit malamig pa kunti, hindi naman sa malamig, yung malamig, pwede na yan pwede na yan ibigay kaagad kay patient. The same way as cryoprecipitate. Uunti lang din si cryoprep. Ang problema lang dito, kung for example, hindi nyo naibigay on time or hindi na naibigay, hindi na siya pwede ibalik sa blood bank. Okay? Discarded na yan. Check your hospital protocol. Kasi meron sa kanila, kapag hindi pa nagamit within 1 hour, kailangan ibalik mo na kaagad. Okay? Pero kapag yung tumagal pa, hindi na yan binabalik. At tinatapon na. Okay? Ayun. O bakit ganun yun? Meron kasi silang meron kasing nakalagay dyan sa kanila, even yung red blood cells, meron kasi silang citrate. Okay? It's somewhat like a preservative kasi nilalagay yan sa refrigerator, di ba? So, mangyayari dyan, kapag ang red blood cells o yung PAC-RBC, kapag lumampas ng 4 hours, nag-i-start na yan na nagre-release na ng citrate yung dugo. Kung pag nagiging obvious na doon sa kanya. Kaya nga, ang natin, kailangan ang blood transfusion natin is to finish within 4 hours. Bakit? Kasi once na-circulate na yan sa natin, sa skin, sa blood transfusion, sa blood vessels, yung ibang mga product na yan, iihian na yan ilalabas na, kunin na lang nila yung mga RBCs. Pero kapag tinagal mo, umabot ng kunyari, dinala ng dugo, hindi mo pa kaagad na transfuse. After 1 hour, saka mo na transfuse. So, ilan na yun? Tapos, transfuse mo, ang bagal talaga. So, yung 1 hour na extra na, bago mo i-transfuse, plus ilagay mo mga 5 hours yan, marami ng mga citrates na lumalabas dyan. So, hindi na maganda sa pasyente. Kaya, isa ito sa mga tinatawag natin masasabing mayroon mga post-transfusion reaction. Okay? So always, RBC should be transfused within 4 hours lang talaga. So para makuha niyo yung 4 hours, make sure that your IV is patent. And it should always be, what do you call this? Gauge 18. Okay, kasi kung gauge 14 ka, gauge 20 yung pink, hindi papasok kasi malapot yung dugo di ba? At saka lagi-lagi bago nyo i-transfuse ang dugo, i-prime muna with saline ang IV tubing. Okay? Okay, next, fibrinolytic inhibitors. Itong mga tranexamic acid, okay, and the aminocaprioic acid. Okay? So ito sila ay mga gamot para ang tawag nito tranexamic acid, ito ay para mag-clot ang dugo. Okay? The same way as yung aminocaprioic acid, ito naman is an anti-fibrinolytic kind of drugs. Ibig sabihin, nag-i-stop siya ng fibrin. Joanna, ano yun?
Sorry po, napindot lang po.
Okay. So, yung paano ang action ni fibrinolytic? Bakit kailangan bigyan natin ng fibrinolytic si patient? Inhibitor. Bakit kailangan natin gumamit ng inhibitor? Kasi siya yun mag-hinder, di ba sa clotting cascade, si plasminogen will be converted to plasmin, and then si plasmin will activate the catalysis or the catalytic action of yung sa fibrin. Okay? Kaya nagkakaroon ng lysis, breakdown. Okay? So, pag magbigay tayo ng aminocaproic acid, hinihinto niya ang binding ng itong gamot na to. Pag hinihinto niya ang binding ng plasminogen para hindi siya ma-convert into plasmid. So, walang mangyayaring fibrinolysis. Okay. Anticoagulant heparin, low molecular weight heparin is given after the acute phase. Ibig sabihin, pag acute phase, heparin muna ang binibigay by IV, via infusion pump. Okay, by infusion pump. So, after 2 or 3 days, mag-i-start na sila ngayon ng Coumadin oral kung naka-recover si patient. Now, bakit? Paano yan, ma'am? Ihinto na ba natin? Hindi. Continuous pa rin ang gamot ng heparin infusion while you start the Coumadin. Bakit? Coumadin or the warfarin. So, bakit yan, ma'am? Kasi si Coumadin, ang action nito after 3 days pa. So, i-count nyo yun, kailan nyo na-start yung Coumadin, on the 3rd day, saka ngayon i-stop si heparin infusion. Okay? And then continuous na ang Coumadin. So, ano naman tong low molecular? So, usually, kapag okay na, stable na ang INR ni patient using the dose of the warfarin, binibigyan din natin siya ng low molecular weight. Ito ay by sub-Q injection. And even sa pag-discharge ng si patient, pwedeng sub-Q pa rin ng low molecular weight heparin. But again, nursing management dyan, si warfarin kasi delikado. Okay? Kaya meron tayo after every 3rd dose, ginagawa natin sila na warfarin level to determine if nasa therapeutic range pa sila. Kapag meron kasi silang target range, target ng INR. Kapag kasi ang INR sumobra at tapos nakita natin sa warfarin level is mas mataas sa therapeutic range, toxic na yun, delikado yun. Okay? This can also magiging dysregulated na rin ang clotting factor natin dyan. Okay? So, kailangan ito ay nasa therapeutic range lang. So, every after 3rd dose, ayan. Nakalimutan ko pala, ang antibiotics din ganyan, yung mga toxic na antibiotics, every after 3rd dose, kinukuhaan natin ng level. Okay? This is to determine kung nasa therapeutic range ba sila o hindi. Kung hindi kasi, this will lead to toxicity. Now, dito sa Pilipinas, wala tayong ganyan. Wala tayo. So, kayo yun, keep watch. Minsan, Dok, baka ilang dose na ito, Dok? Hindi pwede ba natin hindi ba ito kailangan i-determine natin yung serum level nila? Yung mga ganyan. Pero sa amin kasi, automatic na yan, protocol na yan. Every after, kasi minsan mga doktor nakakalimutan yan. So, every after 3rd dose, nila-level na namin. Ino-order na namin yan. So, doon kasi walang problema. Dito kasi, pagkagalaw nyo, pera. Pagkagalaw nyo, babayan si patient. So, iba ang environment, iba yung sistema. Okay? Pero yung ginagawa natin is part of preventive measures to prevent further injury sa pasyente. Para at least alam natin within the therapeutic management pa sila. Okay? The same way as, may nakalimutan pala ko kanina, kapag pala meron antibiotics, meron tayong automatic stop dates. Pero I don't think so that it is being implemented in the Philippines. Ang automatic stop date is that if the patient is receiving IV antibiotics, automatic mag-stop yan sa 7th day, the last dose on the 7th day. So, ang role namin as a nurse, nire-remind natin yung doktor, Dok, itong antibiotic niya, 7th day na ito bukas ng gabi. So, do you think we still have to continue this or ano ang gusto mo daw? Ayun. Kasi kailangan talaga i-stop na yan. Or change dose or replace with other antibiotics sa doktor. But there are some instances sinasabi ni Dr. Yes, continue for 4 more days. O, di continue. Tapos pero nakasulat na sa card 4 more days. Due on. Okay. Kung ano, due yun, i-calculate yun, di ba? Due kunyari, ano na ngayon, 24 or sa 29 na siya, review yun sa 29. Okay, so gano'n. Pag oral antibiotics naman, that is 10 days. Okay? 10 days to 14 days. So, pag umabot na sa 10 days, pag nag-ground tutor man niya, dapat 10 days yung sumunod, antibiotic niya, continue po ba natin? Okay, si Dr. Learn yan decide sa inyo. Ay, oo, 10 days na pala. Sige, continue natin for another 4 days. So, continue natin silang atin natin medyo nag-recover na siya. Pero kailangan natin malaman na kung talaga-recover siya and then i-discontinue natin. So, pag yan ang sinabi niya, after pinakasan sa days, remind my Lord, days to, okay na ba? Pwede na ba yan? Or continue na natin? Kasi, remember guys, kayo ang subject na patient, kayo ang meeting ng mga conditions like that. Okay? Protein inhibitor or ibuprofen inhibitor is a substance that action of the protein converted in proton to phosphate. Okay? Para walang clotting, ayan, meron tayong mga ibuprofen. Fluid and electrolyte management for care, okay na yan sa iyo, pain management, okay na rin siguro sa iyo. Okay, so, tayo. Dito sa nursing management, ano ba? Continuous assessment ay alam na pag sa ICU every 15 days. Monitoring namin ay alam na pag-popular artery catheter, pag-CCV lights like that, kailangan lalalaga sa kailangan sa user, and like that. So, you can get that already daily. Okay? May mga SOP, levelly, and more tests to kailangan lagi yan ginagawa. And then, electrolyte management, usually, monitored every 6 hours, depends on the doctor's order, if okay na patient, yung tapos lang ang activation niya, pwede daily na ito, okay, but if what's electrolyte, so it goes to patient has this situation, is taking a lot of medications that can give the liver and the renal status talaga magiging okay, so yun nga. And transfusion management, sinabi ko na sa inyo, pain management. Those in pain management, there are different kinds of modalities dahil it depends on the condition of the patient. Meron tayong pain control na analgesia, that is we're going to use a machine na nakakabit kay patient and ini-infuse for morphine. This is just to make the pain tolerable. But then, watch talaga kasi morphine yan, it can stop the breathing of the patient. Wound care, respiratory support, kapag ito ay meron siya, kapag ventilator siya, remember, pag highly humidified yung air na nag-travel from the corrugated tube to the tissue tube, kasi naka-tissue yan, take note na yung mga fluid na buo sa corrugated tube is in milk nyo kasi yung hindi milk yan kasi mapupuno yan and can hinder the passage of the oxygenated blood. So, tanggalin nyo yung mga fluid or tubig sa corrugated tube traveling from the machine to the tissue tube. Okay. Neurological care, GCS yan, patient and family education, once na-recover si patient, pero nandiyan pa sa hospital, pwede na natin i-start yan kasi we are ready for discharge, part ng discharge planning dyan. Psychological support and emotional support, alam niyo na yan. Infection control, napaka-importante sa ICU because ICU is the ground for pseudomonas and other kind of pathogen, particularly MRSA. So proper hand washing talaga ang kailangan, at saka alam mo, hindi kami itong nurse na tumatayo sa bedside, hindi kami nagaganyan sa hospital. We use plastic apron to protect our uniform. And then paglabas namin sa room, tinatanggal namin yun. So malakas kami sa paggamit ng plastic apron. Mura lang naman, pero at least protected tayo. And then when we move to other patients' room, we change plastic apron. Okay? Ayun. But again, iba-iba naman talaga ang mga, what do you call this, mga sistema. Given yung mga IV, check yan, 24 hours, 72 hours, kung may mga signs, remove, replace, or reinsert. Then, yung mga IV bag. Okay, dito sa atin sa Pilipinas, meron silang protocol na everyday, depende sa hospital, everyday it should be changed. Kasi mas, sabihin natin mahal ay ang urine bag. Pero mas mahal kapag mag-stay o mag-prolong si patient sa hospital dahil sa infection. Okay? So, prevent natin yun. Medication administration principles, alam niyo na yan. Collaboration and communication, alam niyo na yan. Collaborate niyo sa doctor, sa nutritionist, sa pharmacist, chuchu, and things like that. Physiotherapists, respiratory therapists, and documentation. So, finish. Next reporter na tayo. May question ba? Walang question? Okay, so make sure you understand, guys, ha? Okay, so third group, yung ano na ba tayo? TBI na ba? TBI na ba?
Yes po, ma'am.
Okay, sige. Prepare na.
Alright, so good afternoon everyone. So we are the group 5. So for today, we're going to discuss about the traumatic brain injury. So the members are Geronimo, Indita, Lualhati, Modina, Nardo, Renabor, and Valle. So without further ado, let's start the reporting na po, or the discussion rather. So here are the contents. So first, we're going to discuss about the definition of the TBI, or the traumatic brain injury, followed by the assessment. So we're going to discuss about the different assessment parameters and tools na pwedeng gamitin dito sa TBI, as well as yung mga clinical manifestations of TBI. Then meron din pong diagnostics, etiology, as well as yung mga pathophysiology, kung paano bang nag-usbong talaga yung TBI, paano siya naka-apekto sa katawan natin. Then as well as yung mga pharmacotherapy and yung care of management, which is the nursing and yung medical management. So may I call on Mr. Modina to report po the definition of TBI.
Thank you po. So next naman po is for the definition of the TBI, or traumatic brain injury. So ano nga ba yung TBI? So TBI refers to the damage to the brain caused by an external physical force resulting in temporary or permanent impairment of cognitive, physical, and psychosocial function. So yung TBI po is injury po siya that affects how our brain works po. And it is the most common cause po of TBI is yung fall, yung mga pagkadulas po, and motor vehicular accident, and sport accident, or an assault, yung mga nabarel or nasaksak, ganun. And next naman po is according to WHO, nire-recognize po nila yung TBI as a leading cause of mortality and long-term disability, particularly among young adults and the elderly. In the US, there are 2.5 million TBI cases each year, while in the Philippines, there are approximately 300,000 cases per year. So, that's why po yung TBI po is characterized po as one of the most major cause of preventable death and disability. So, next slide po. So, next naman po is the traumatic brain injury may occur in one of two ways po or mechanism po to ng traumatic brain injury. So, meron po tayo dito yung una is closed or blunt brain injury. It occurs when there is a non-penetrating injury to the brain with no break in the skull. So, yung mga example po dito is yung napukpok sa ulo, ganun po, yung nabagok or yung fall. So, next naman po is yung penetrating brain injury. Results when an object has penetrated the skull and directly damaged the brain tissue. So, yung example po dito is yung gunshot wounds or stab wounds such as yung knives or other pointed objects na nagpenetrate po sa brain po natin or sa skull na nagkakos po ng severe damage po sa brain. So, next slide po. So next naman po is yung types of traumatic brain injury. We have the contusion, concussion, intracranial hemorrhage, and diffuse axonal injury. So for the contusion, a bruise and damage in a specific, it is a bruise and damage in a specific area of the brain. So a contusion po causes a bleeding and swelling po inside of the brain around the area kung saan po siya natamaan or yung site po kung saan po na-struck yung brain po natin during an accident or kung ano man po yung cause. And sa contusion po, we have two types, the coup injury and the counter-coup injury. Sa coup injury po, it occurs at the site of the trauma. So kung saan lang po na bagok, doon lang po yung injury sa brain natin. And sa counter-coup naman po, yung occurs at the opposite side of the trauma. Kumbaga po dito, yung nag-rebound po yung brain natin, kaya nagkaroon po ng injury sa opposite side ng brain po natin. So next naman po is the concussion. It causes an deceleration force with no apparent structural damage to the brain. Ito po yung yung common type of traumatic brain injury. So next po is the intracranial hemorrhage. It collections of blood in the brain. So from the word po hemorrhage, so meron pong bleeding po sa intracranial or sa brain po natin. So we have three types, yung subdural hematoma, epidural hematoma, and intracerebral hematoma. So yung subdural hematoma po is below the dura lang po or yung blood collection niya lang po is under lang po ng thin layer of the protection of the brain. So nasa bandang skull lang po siya. So yung epidural naman po above the dura. Collection po siya between the skull and the brain, yung bleeding po. And next po is the intracerebral hematoma is ito na po yung bleeding na nasa brain na po talaga. So lastly po is the diffuse axonal injury or DAI, the shearing or tearing of nerve fibers throughout the brain. So DAI po is most severe types of traumatic injury. They occur po when the brain is shaken or twisted po inside the skull. So as the brain twists, the cerebral tissue slides back and forth until the long connecting fibers in the brain nagtitear po, ganun. So next slide po.
So now, let's proceed na po with the assessment. So again, kapag sinabi natin TBI or traumatic brain injury, nagkakaroon tayo ng injury sa brain to the point na naaapektuhan na nito yung normal function ng brain natin. And we all know that brain is incredibly important siya kasi siya yung central control center ng katawan natin. At once na nagkaroon ng problema doon sa brain, probably affected yung lahat, like yung memory, yung attention, the way we speak, the way we write, and as well as yung mga motor function ng katawan natin. Now, these are some ways para ma-assess natin yung patients or clients natin na may TBI or possible for TBI. So, first is history taking. So, kailangan magkaroon tayo ng baseline data so we can gain insights kung anong specific circumstances of injury ba yung nangyari sa pasyente natin. So now, below are some of the guide questions we can use. So first, alamin natin kung kailan ba nangyari yung injury, like kung anong oras or anong araw nangyari yun. Then second one, we have to identify kung ano yung dahilan or pinagmulan ng injury. Like nahulog ba si patient kasi nadulas kaya nabagok, tapos nagkaroon ba ng car accident, then so on and so forth. So marami kasi tayong risk factors and causes na pwedeng mag-cause nga sa TBI. Then later, i-discuss namin yan. So then lastly, ano yung naging direction ng pagkabunggo ng head para mag-cause ng injury sa brain. So kung saan parte ng ulo, kailangan natin ma-identify yon. Like for example, let's say according to patient, sabi niya paharap daw yung impact. So most likely frontal lobe yung naapektuhan nun. So something like that. Then also, gumagamit din tayo ng mga assessment parameters such as ito nga yung eye-opening and responsiveness. So yung eye-opening and responsiveness, isa lang sila sa mga fundamental indicators ng pag-identify ng level of consciousness or LOC ng pasyente natin. So itong LOC or level of consciousness, ine-evaluate niya kung gaano ba ka-severe yung injury. So, later, madadaanan natin yung eye function sa GCS or the Glasgow Coma Scale. So, isa rin tong assessment tool para ma-assess yung TBI. Then, of course, vital signs. So, vital signs are also monitored here. So, let's say, nagkaroon ng intracranial hemorrhage si patient. So, most likely, tachycardic and hypotensive yan dahil nga mayroong bleeding. So, hindi mawawala si vital signs sa lahat ng nursing journey natin or any procedures kasi because through this, we can able to track down the status of patients and indicator kasi siya kung may health problems ba yung pasyente natin. And hindi pwedeng basta-basta hulaan na lang yung RR, yung BP, yung temp, and etc. Kasi very important talaga siya. And di ba nga, alam ko narinig nyo na rin naman na sabi nga nila, di ba, na Bachelor of Science, major in Vital Signs. So, totoo naman kasi talaga yun kasi nga vital signs is importante talaga yan na kunin and i-monitor. And sa ICU, most likely Q15, Q30, and Q1 yung pag-VS dyan. And nagbabago na lang yan, depende sa order ni Doc. So, again, technically, as we can see here sa slide natin, yung VS ng TBI may vary. Sorry, wait lang po. Okay, sorry po for interruptions. Again, yun nga. So, yung vital signs sa DBI, nagva-vary yan. Kasi, meron tayong iba't ibang different types ng DBI. So, again, eto. So, first off is lower BP. So, may hypotensive siya. Hypertensive siya kapag increase yung ICP. So, kapag mataas ang ICP, natitrigger niya yung Cushing's reflex. So, based sa nakuha naming studies, yung Cushing reflex daw, ito daw yung one of the body's way of trying to maintain yung blood flow doon sa brain. So, hence, nagiging resulta ito para mag-increase yung blood pressure para mag-force ng mas marami pang blood
doon sa brain against the higher ICP. So as well as in some severe TBI po kasi possible na ma-disrupt niya yung autonomic nervous system or yung ANS. Now, yung itong ANS, it controls the involuntary bodily function such as yung blood pressure regulation. Now, kapag ito naman, hypotension naman siya kapag nagkaroon ng bleeding, specifically in the brainstem. So, this bleeding, nire-reduce niya yung amount ng blood na available doon sa brain. And it's a very concerning sign kasi pwedeng ma-compromise yung cerebral perfusion. And once na na-compromise yung cerebral perfusion, of course, affected talaga yung katawan natin, yung processes natin and all. Now, proceed naman tayo sa PR. So, yung pulse rate naman, in response to ICP, in response to increased ICP, bradycardia is common naman. Now, question, kasi kanina pa tayo mention ng ICP. So, ano bang nangyayari dito sa ICP kapag increase? So, kapag mataas yung ICP, ibig sabihin lang nito, mataas yung pressure na nasa loob ng skull, specifically doon sa brain, and yung mga surrounding structures nito. Now, when there's too much pressure inside, sinasabi ng katawan natin kay heart na, like, oh, heart, ganyan, mag-pump ka ng blood na less force lang. Kasi kapag slow yung heartbeat, pwedeng maging steady yung supply ng oxygen and nutrients papunta doon sa brain kahit na may extra pressure nga sa loob. Now, on the other hand, kapag increase naman ng sympathetic nervous system activity or yung SNS, it can lead to tachycardia naman. Now, if we can still recall in our ANAPHY or Anatomy and Physiology, di ba, meron tayong dalawa, the SNS, the sympathetic and the parasympathetic nervous system. So, itong SNS, it governs the fight or flight response, while yung PNS naman, siya naman yung nagkocontrol ng rest and digest. So, during stressful situations, si SNS ang gumagana. Ngayon, yung TBI or traumatic brain injury is a stressful event siya sa katawan natin. Therefore, nag-activate ang ating SNS, leading for increased heart rate. Now, going to the RR, kapag RR naman yan, affected din kasi yung mga respiratory control centers natin sa brain. So, it can lead to hypoxia, yun nga, yung low oxygen levels. Lalo na kapag na-damage talaga yung brainstem natin. Kasi yung brainstem natin yung responsible for regulating breathing. Now, to compensate for the potential oxygen deficits, yun nga, mababa nga, intake dun sa ating katawan. So, ayun, like magtataas yung respiratory rate natin para ma-compensate yun. Yung low oxygen deficit. Now, kapag temp naman, so katulad nga ng nasabi natin for the previous lessons, so fever is an inflammatory response and hindi talaga siya sakit. So, since may injury, na-trigger yung brain para mag-release ng pro-inflammatory cytokines, yung mga cytokine storms. Nagkakaroon ng cytokine storms, so maraming production ng cytokines na later on makakontribute para magkaroon ng fever response. Now, ito, meron din tayong mga motor response. Yung mga motor function indicator, yan, indicator din yan ng mga neurological function. Why? Kasi di ba yung motor responses natin, they are closely connected sa brain function natin dahil, what you call this? Dahil parang, dahil nire-reflect nito yung integrity ng central nervous system natin, which includes yung brain nga natin and yung spinal cord natin. Then again, ayan, patient's response to tactile stimuli, if unconscious naman to. So, indicator din yan ng neurological function. So, later on, hindi pala, kasunod na natin yung GCS. So, dito natin ma-explain yung connection ng pain, yung mga pain stimuli doon sa ating patient's response. Now, again, dito na tayo sa GCS. So, I know nadaanan na natin siya before sa mga previous lessons natin. So, this is just a recall lang. So, kapag GCS, tinatawag siyang Glasgow Coma Scale. So, ito yung primary tool talaga for accessing the level of consciousness ng pasyente natin. Now, yung level of consciousness kasi, ito yung nagsasabi kung gaano ka-alert or responsive yung pasyente natin sa mga stimuli. So, here nahati siya. So, wait lang. Ayan. So, this is the sample. This is the GCS, I mean. So, eto kasi, nahati siya sa tatlong parts. So, lagi lang natin tandaan, meron tayong EVM. So, E stands for eye-opening response, V stands for verbal response, and M stands for motor response. So, meron din tayong basis dito. So, the maximum points na pwedeng maging GCS score is 15 points and lowest naman is 3 points. So obviously, walang 0 GCS or 1 GCS score lang. Now, ayan, let's take a look at the basis here. So etong nasa baba ng Glasgow Coma Scale. So yung mild TBI, usually ang GCS score niyan is 13 to 15, moderate is 9 to 12, severe 4 to 8, then persistent vegetative state. So yung parang wala na talaga like sobrang unconscious na ni patient, yun nga yung 3 points. Again, 3 points is the lowest. So proceed tayo dito. So, paano ba kukunin ang GCS or yung Glasgow Coma Scale? So, etong Glasgow Coma Scale, describe ko muna kung ano yung components ng mga yan. So, pag spontaneous, yung eye opening, ibig sabihin, normally na nagko-close and open yung eyes without any external stimulation. So, parang well-functioning siya, automatic lang siya nagko-close and open yung eyes. So, we can score the patient as 4 points. Then, kapag meron naman eye response based sa verbal commands, so let's say for example, sinabi natin sa pasyente natin na, "Ma'am, sir, pwede niyo po bang idilat mga mata niyo?" So, kapag nagkaroon siya ng eye response doon, so we can score that as 3 points. Yun yung to voice. Then, kapag naman may response due to painful stimulus, let's say by pinching or applying pressure sa fingernail bed, nagkakaroon ng pag-open yung eyes ni patient. So, ayun, pwede natin siyang i-score as 2 points. So, in my personal experience po, yung ginagawa sa ICU na pinagjujutihan ko is kukurutin yung pectoralis or pipinch yung pectoralis major muscle or yung nipples kasi mas malakas yung pain stimuli doon. So, kapag 1, ayan nga, none yung point niya. So, walang response sa kahit anong na-mention ko. Then, verbal response naman, kapag fully oriented yung pasyente, nakakapagsagot siya sa mga questions at nakakausap natin siya ng maayos. So, let's say, for example, sabi natin sa pasyente natin na, "Ma'am, sir, like, alam niyo po ba ang pangalan niyo? Saan ka nakatira? Like, alam mo kung nasaan ka ngayon, birthday mo, so on and so forth." So, kapag nag-respond siya, normally, so again, 5 points siya. Kapag nakakapagsalita naman siya or nakakasagot si patient, pero some questions lang yung nasasagot niya ng tama, so confused siya, so let's give her or him ng 4 points. Then, pag inappropriate words naman, kapag sumasagot sila na unrelated naman doon sa questions, 3 points lang siya. Like, let's say, gumagamit nga siya, nagsasalita siya ng words, pero hindi naman coherent or related sa mga questions. So, 3 points. Then, kapag nagpo-produce naman ng sounds lang si patient na hindi naman maintindihan, like nagmo-mumble lang siya, so 2 points lang. Then, 1 is the lowest kapag wala. Then lastly, kapag nagre-respond naman, motor response naman, kapag nagre-respond siya based sa command, let's say, sabihin natin sa patient na, "Ma'am, sir, pwede niyo po bang itaas yung kamay niyo? Kaya niyo po bang igalaw yung left leg niyo?" So, kapag nag-respond si patient doon, automatic 6 points siya. Pero kapag may response sa pain pero hindi siya nakakapagsunod sa verbal command, so 5 points lang siya and ito yung localizes pain na sinasabi natin. At nung withdraw, kapag ang pasyente naman ay nagre-react sa pamamagitan po ng kunwari pag-urong o pag-alis sa isang pain stimulus. For example, yun nga yung pag-urong sa pagkurot, 'di ba? Kunwari pininch mo yung sa nipple area ta's umurong siya. So yun, yun yung withdraws to pain. Then pero dito kasi 'pag withdraws to pain, hindi kaya ni patient tukuyan or malaman kung saan galing yung pain stimulus na yun. Basta alam niya, nakaramdam lang siya na may pain. Then kapag si patient naman may abnormal and rigid extension ng arms and legs in response to pain, yun yung sinasabi nating decerebrate posturing. Pag decorticate posturing naman, nagpapakita 'to ng abnormal posturing in response dun sa pain. For example, yung braso ni patient naka-flex or naka-contract sa katawan and yung mga kamay niya ay nakapatong sa chest. So, habang yung legs niya naman ay naka-extend. So, gets niyo, parang ano, parang abnormal po, hindi appropriate yung position o yung posture ni patient nun. So, 2 points siya. Then lastly is none kapag wala. So, bale kapag gagamitin natin siya, identify muna natin yung characteristics nga depende sa score and then i-add natin yung total niya and then that's the GCS score. So, example, E plus V plus M. So, kung perfect siya, like 4, then plus 5, plus 6, matic, 15 points sa GCS 15. So, ganun na po yung paggamit ng GCS. Then, proceed tayo sa characteristics or the manifestation. So, ayan, altered loss of consciousness. If we can still recall in our anaphy again, so, di ba yung brain natin nag-work siya by sending electrical signals sa mga nerve cells. So, these signals po, they are the ones na they are the ones na nagko-control ng awareness and alertness. Pero dahil nga sa impact, na-damage and na-injured na yung brain. Wait lang po. Pwede po ba ma'am mag-proceed po muna kami sa pathophysiology before the manifestations? Kasi po may kailangan pong gawin yung magre-report ng patho. So, yun guys. Before natin i-discuss yung characteristics, let's proceed muna po sa pathophysiology. So, this is the pathophysiology.
Hello po, good afternoon. So, this is the pathophysiology of TBI or what we call traumatic brain injury. So, sa traumatic brain injury, as you can see, may two categories siya, which is the primary and the secondary. So, yung primary, ang sinasabi nating primary injury, nag-o-occur siya at the time of the trauma, while the secondary naman, nag-o-occur siya after ng initial trauma. So, definitely, pagkatapos ng primary, kung lalalaman yung injury, definitely magiging turn into secondary brain injury, which is fatal. So generally, ang brain natin is may mini-maintain na values. So example, pag impaired ang cerebral autoregulation, ang nangyayari is nag-i-increase yung ICP or yung intracranial pressure natin. So yung CPP or yung cerebral perfusion pressure, yung nangyayari sa kanya is nagde-decrease. So ngayon, pag nag-decrease yung CPP natin, bakit kaya nagde-decrease yung CPP? Siyempre, nagde-decrease yung CPP kasi nga syempre, nag-increase yung ICP. So, parang, yung tawag? Parang may compensatory mechanism din yung brain. So, example, si ICP nag-increase, so si CPP magde-decrease. So ngayon, pag nag-decrease si CPP, yung blood flow natin na nag-aano sa may brain is nagde-decrease. So ngayon, yung oxygen in the brain, so yun na, tuloy-tuloy na yun. So yung oxygen sa brain natin is nagde-decrease, as well as the nutrition hanggang mag-undergo yung brain natin ng hypoxia, then necrosis. What do you mean by necrosis ba? Di ba pag sinabing necrosis, death of cell. So ayun. So tapos, di ba example, after nun, pag hindi na nakakapag-bind yung oxygen sa hemoglobin, di ba yung nangyayari is nag-i-increase yung lactic acid natin. So, nagkakaroon tayo ng anaerobic metabolism, which eventually, yung nagli-lead sa organ dysfunction. So, ayun na nga. So, as you can see there, actually, Yung sa primary naman, simple lang naman siya actually. Tingin lang kayo sa may red na red na na box or what na oblong pala. I'm so sorry. So, as you can see, pag nagsuffer yung ating katawan ng traumatic brain injury, yung nangyayari is, sa primary, yung nangyayari actually lang is example, nagsaswelling lang or nagbi-build yung intracranial volume. So ngayon, yung natin, yung right cranium natin is, yung cranium natin, parang, kumbaga, walang room for expansion. Example, imagine nyo na, yung brain natin is, kumbaga yung brain natin is nasa loob, tapos may ICP, tapos skull. Parang ganun siya. So imagine nyo yun, example, kung may hematoma doon or bruising na malaki doon. Example, sa likod ng brain, kumbaga nawawalan ng space yung brain doon sa doon sa loob. Sana nyo, na-visualize nyo. So, ayun. So, example, so wala na siyang room for expansion. So, yung nangyayari, yung ICP natin is nag-i-increase. So, ngayon, pag nag-increase yung ICP, ayun nga yung sinasabi ko kanina, yung blood flow sa brain nagiging slow. So, ano yung mangyayari pag naging slow? So, nag-impaired yung cerebral autoaggregation kung saan tumataas yung ICP. Pag, example, may bleeding, yung nangyayari is tumataas yung white blood cell, tumataas yung CSF, bumababa yung BP, tapos bumababa din yung platelet, as well as hematocrit, HBG, and RBC. Bakit bumababa tong natin, mga RBC, HBG, HCT? Kasi nga, impaired ang ating, what they call this, perfusion, tissue perfusion. So, ayun. So, ayun na. So, since impaired nga, so nag-lead siya into cerebral hypoxia or ischemia. Nag-occur yun. So, ngayon, after nun, sa may naman, sa secondary, di ba, yun na nga, nagkaroon na ng impairment. Sa secondary, mas pinalala. Kumbaga, mas pinalala siya. So, yung mangyayari dito is, di ba, impaired na yung autoregulation. So, si ICP natin, dito sa secondary, is nagko-continue lang siya mag-rise. While yung CPP tsaka yung CPF nagdi-decrease. So, pag nag-decrease yun, anong mangyayari? Siyempre, wala na. Kasi hindi na nagpo-perfuse lang maayos. So, yung cerebral blood flow natin sa brain, nagsisis. Kumbaga, ayun na nga, nagiging brain death. So, as you can see there sa secondary, meron tayong nagkakaroon ng cerebral edema nga, and then impaired metabolism. So, ayun na nga. So, yung signs and symptoms din nagkakaroon ng hypotension, yung individual, nagkakaroon ng anemia or hypothermia, and then pericardia and hypoxemia. So, actually, yung nangyayari pala sa brain herniation naman, kasi wala na kasing space nga yung yung brain natin. So, nagtatry yung brain natin na lumabas ng konti, ganun. So, ayun lang naman yung nangyayari dito sa primary and secondary. Basta tandaan nyo lang is, pag primary, hindi pa siya ganun ka, hindi pa siya, ganun ka, basta yung mas malala dito is yung secondary. Thank you po.
So, again, going back, so ito po yung mga characteristics. So, yun nga, yung altered or loss of consciousness. Then, merong headache din. Kasi, following the initial injury, yung brain natin pwede rin mag-swell and maging inflame. And itong pressure na to, pwedeng mag-accumulate yun sa surrounding structures and mga protective layers ng brain, resulting in headache. Then, memory problems din. Kasi yung TBI, it can cause physical damage nga sa brain, including yung injury doon sa ating hippocampus and yung other brain regions na involved sa memory formation. Yung hippocampus, located siya sa ilalim ng temporal lobe at yung major role niya is learning and memory. Now, once na nagka-damage nga doon, pwedeng ma-disrupt yung neural networks niya na responsible for encoding and storing ng mga memories. Next, yan, meron din tayong problems with speaking, understanding, and writing. Kasi 'di ba yung CNS natin, yung brain natin, responsible din siya for the writing, the language skills ng ating katawan. Then, meron din tayong sensory disturbances such as yung blurred vision, hearing loss, or altered taste. So, yung shearing or yung stretching ng mga nerve fibers na cause ng injury, pwede yun maka-disrupt sa connectivity ng sensory receptors and sa mismong brain. So, leading nga para magkaroon ng changes or alterations on how our sensory information is processed. Then, meron din tayo ditong mood and behavioral changes, as well as itong convulsions or seizures. So again, kapag disrupted yung electrical activity sa brain, pwedeng mag-trigger ito na mag-release ng napakaraming excitatory neurotransmitters like yung glutamate. So kapag naging excessive na yung neurotransmitters na ito, pwede kasi siyang mag-overstimulate ng puwede siyang mag-overstimulate sa neurons, leading to abnormal firing ng mga electrical signals, which may result later on ng seizures or convulsions. So, nagkakaroon ng excessive release na rin dito. Dito napapasok yung mga excessive release ng mga ating stress hormones like mga norepi and epi. And as well as yung inflammatory response, 'di ba nga, as we discussed earlier, yung hyperthermia or yung increased temperature is an inflammatory response. So, as the body temperature rises, it can lead to increased excitability of neurons sa ating brain. Then, meron din tayong sleep disturbances. Then, sensitivity to light or sound. So, pwedeng affected din yung ating photophobia, yung sensitivity to light, and the sensitivity to sound, which is the phonophobia. Then, merong nausea and vomiting kasi pwede din yung pwede ding ma-disrupt ng TBI yung regulation ng ating GI system. Then, lastly is itong weakness, paralysis, or coordination problems. Next reporter po.
So we have the diagnostics. So the first one would be the CT scan. CT scan is usually the first to be performed for a suspected traumatic brain injury, as it can quickly visualize fractures and hemorrhage, hematomas, and contusions and brain swelling. Then next we have the intracranial pressure monitoring. It is a test that measures the pressure inside the skull of a person who has had brain injury or other problems. It involves the use of small pressure sensitive probe that is inserted through the skull and attached to a monitor. It helps physicians determine kung high or low CSF pressure po. Then next naman, yung MRI, it it does provide detailed images ng brain more than sa CT scan. However, MRI likely would not be used as a part of initial TBI assessment because it takes too long to complete. Pero it can be used for follow-up examinations po. Then a summarizing of what was said earlier during the explanation of pathophysiology, for the expected lab outcomes or results for primary TBI, we have ICP increased due to the brain swelling or bleeding of more than 20 mmHg. So no room for expansion in rigid cranium may give an increase in WBC, increase in cerebrospinal fluid of more than 6,000 ng per ml. A drop in blood pressure, drop in platelet count, drop in hematocrit and hemoglobin. Next, secondary TBI. ICP continues to rise, however, CPP and CPF decreases. And there's an excess in catabolic hormones then, and blood glucose is elevated po. Ayun po. Next reporter.
Hello everyone. So next is going to discuss the etiology of the traumatic brain injury or what we call the TBI. So here, there are many factors that causing the TBI, include the following. The first one is the fall injury. So here, this is the most frequent causes of TBI, especially in elderly individuals and small children. So such as the falls from the bed or ladder, downstairs, in the bath, and other falls. Kasi sa mga elderly, their muscles become more weaker and brittle, which they are more likely prone to fall injuries. And sa mga bata naman like toddlers, ages of 1 to 3 years old, is because their motor skills and coordinations are not fully developed. So that's why when we are in a hospital duties and taking care of every patient, we elevate their side rails to prevent from fall injury. So next one here is the vehicle-related collisions or the vehicle accidents. So mostly the accident or collision involving cars, motorcycles, or bicycles, which can affect the brain. So this is the reason why we need to wear seat belts, helmet, and other protective measures to prevent from the possible TBI. So next is the violence. So violence here, such as the gunshot wounds, domestic violence, and the child abuse and other assaults, are common causes of uh, violence that can lead to TBI. So here, the best example is the shaken baby syndrome, which a type of traumatic brain injury in infants caused by the violent shaking. So to prevent this is to educate the mother and her family to never shake a baby, especially when they are crying, because there's a chance or risk for TBI. And then next for the sports injuries. So those athletes that often engaging in high impact sports tulad ng football, hockey, boxing, etc. So they are particularly vulnerable to TBIs because of the sudden impact or blow to the heads. So here the only preventions is to use protective equipment as well, such as helmet, padding, shin, high or mouth guards. And then lastly, for the explosive blasts. So blasts or explosive incidents can also lead to TBI, which is caused by the force of the explosion causing the injury to the brain tissue. So yung severity ng TBI can depend based on the intensity sa intensity and then the proximity to the explosion and then yung individual overall health. And then so here by identifying the explosion hazards to the specific areas can prevent ourselves from that kind of accidents. So next slide.
For pharmacotherapy, TBI medications are administered to treat brain injuries and to prevent further secondary injury to the brain and manage adverse conditions that result from a traumatic brain injury. Medications used during the treatment of injury include diuretics, anticonvulsants, sedative agents, electrolytes, muscle relaxants, and pain reliever, stabilizing the patient's vital parameters and preventing secondary injuries such as cerebral edema, hypotension, and hypoxemia. And many more are the immediate goals of treatment after the brain injury. For diuretics, such as mannitol, we give diuretics to drain excess cerebrospinal fluid and reduce the pressure in the brain. And mannitol is a osmotic diuretic. It works by decreasing the brain water content, which is drained and excreted in the urine. Next is the anticonvulsant, such as gabapentin and phenytoin, um, because from excessive release of neurotransmitters, which are activated by the injury, we give gabapentin or phenytoin to prevent seizures. Next is sedative agents, such as barbiturates. Barbiturates, which have sedative and anticonvulsants property, that may be administered if other methods to lower the intracranial pressure are not effective. Barbiturates may also be administered to induce a medical coma in patients with severe brain injury. For electrolytes, we give magnesium, such as um, traumatic brain injury can lower electrolytes level, which can adversely affect heart function and blood pressure. So, ibig sabihin daw, yung magnesium daw nakakapag-improve ng blood flow sa brain. So, next is muscle relaxers such as diazepam, baclofen, and tizanidine. Muscle relaxers are used to relax muscle cramping and tightening because of injury to motor neurons in the brain, but commonly prescribed are diazepam and baclofen. And lastly, the pain relievers such as paracetamol or ibuprofen. It is used for management of pain from TBI. Thank you po. Next slide po.
So, sa medical management for traumatic brain injury or sa TBI involves a comprehensive and multiple disciplinary approach. So, the specific treatment plan will depend on the severity of the injury and individual patient needs. So, the first is prevention. Sa prevention, wala siyang age or wala siyang I mean, mapapedya, adult, or geria, possible magkaroon ng TBI. So, it's crucial to emphasize prevention to reduce the risk of future TBIs. Like, for sa example, kanina, sa vehicle accident, so using seatbelt sa mga sasakyan or wearing helmet sa motor para maiwasan mabagok yung ulo or mauntog. So, next is primary assessment and stabilization. So, dito, i-ensure natin sa yung patient's airway, breathing, and circulation are stable and address natin kung may any life-threatening issues first. And i-consider din natin dito yung need for intubation and mechanical ventilation if the patient has severe TBI and compromised airway or respiratory function. So dito, papasok din natin dito yung sa body temperature ng patient within normal limits. And maintain din natin yung cerebral perfusion pressure of 50 to 70 millimeters of mercury. And avoid din natin dito yung nauseous stimuli like excessive suctioning or any painful procedures. And mag-administer din ng sedation to reduce agitation. So, the third is imaging and diagnostic test. So, sabi nga kanina, CT scans or MRI or X-rays are typically used to assess the extent and location of brain damage. So, yung sa X-ray may be taken to evaluate for any associated injuries like mga skull fractures or cervical spine injuries. So, dito TBI. So, injuries lang sa may skull fractures. Sa monitoring, I mean neurosurgical intervention. In some cases, surgical interventions like craniotomy or craniotomy may be necessary to relieve intracranial pressure or remove clots or repair damaged blood vessels. And ventriculostomy may be performed to drain cerebrospinal fluid and monitor intracranial pressure. Sa monitoring naman, syempre, hindi mawawala yung vital signs. And continue monitoring ICP or yung intracranial pressure is important in the ICU. So, sa ICU nga, di ba, ang madalas Q15, minsan Q30, minsan Q1 din. So, yung CCP is calculated to ensure adequate blood flow to the brain. So, yung next is medications. Like, yung sa medication may be used to manage symptoms and reduce complications like yung sinabi ni Mr. Geronimo kanina. So, sa nutritional support, adequate nutrition, including enteral or parental feeding, is important to support healing and recovery. Rehabilitation. After stabilization, patients often require rehabilitation to regain lost functions, and this may include physical therapy, occupational therapy, speech therapy, and cognitive rehabilitation. So, next is psychosocial support. So, yung traumatic brain injury can have profound psychological and emotional effects. Like patients and their families may benefit from counseling and support groups. So, papasok din dito yung pag-maintain ng fluid balance with normal saline solution. Next is long-term management. Depending on the severity of TBI, long-term care and follow-up are often required, and this can include ongoing monitoring of cognitive function, behavior, and management of complications that may arise. Next po. Nursing management. So sa nursing management for traumatic brain injuries or TBI is a critical aspect of patient care, and it involves various tasks and responsibilities to ensure the well-being and recovery of TBI patients. So the first is assess and monitoring. Frequent and comprehensive neurological assessments are crucial to monitor changes in the patient's conditions. So, papasok dito yung GCS or yung Glasgow Coma Scale, pupillary reactions, level of consciousness, and yung vital signs. Pwede rin dito yung ICP, continuously monitor intracranial pressure if applicable and ensure it remains within the target range. Airway management includes ventilation. So, maintain a patent airway to ensure proper oxygenation and ventilation. And in some cases, intubation and mechanical ventilation may be necessary. Manage and monitor the patient's breathing, ensuring adequate oxygenation and ventilation, adjust ventilator setting as needed. So, mag-a-administer ng oxygen to maintain partial pressure of arterial oxygen between 90 millimeters of mercury. Cerebral perfusion pressure management or CPP, calculate and monitor CPP to ensure that the brain receives adequate blood flow. It's often necessary to maintain a certain CPP range, which may involve interventions such as blood pressure management. Medication management, ayun nga, yung sinabi ni Mr. Geronimo, administer medication as prescribed, and monitor the patient for any adverse effects of medications and changes in neurological status. So, ICP monitoring, care for and monitor ICP devices if they are in place, or ensure the transducer is leveled at the patient's tragus and geared correctly. Wound care. Attend to any wounds or incisions related to neurological procedures and ensure that the dressing remains clean and dry and watch for signs of infections. Fluid and electrolyte management. So, kanina, ito yung sinabi ko na maintain fluid balance within normal saline solution. So, maintain lang ng fluid and electrolyte balance, as imbalances can affect brain functions. Administer fluids and electrolytes as prescribed, and monitor for signs of dehydration or overhydration. Nutritional support. Administer maternal or parental nutrition as necessary. Monitor the patient's nutritional status and adjust the feeding plan as needed. Mobility and positioning. So, dito, elevate natin yung head ng bed ng patient as prescribed, and maintain din natin yung patient's head and neck in neutral alignment, na no twisting or flexing the neck. And implement din natin yung strategies to preventing pain, thrombosis, and pulmonary embolism, such as early mobilization and the use of compression stockings. So, sa seizure management, be prepared lang to manage sa mga seizures if they occur, or administer anti-seizure medications as prescribed, and provide comfort measures to the patient during and after seizure. Family and patient support. So, educate natin yung family ni patient about sa condition about sa case ni patient, and provide din ng emotional support and education to the patient's family and loved ones. And communicate na rin sa sa patient and sa family about yung condition nga and yung magiging progress in a compassionate and informative manner. Sa rehabilitation support, collaborate with rehabilitation specialists to initiate early mobility and therapy intervention as appropriate for the patient's conditions. And lastly, for documentation, maintain lang natin yung accurate and detailed medical records of the patient's conditions, interventions, and yung response sa treatment ni patient. So, yun lang po. Thank you for listening.
Okay guys, very good. May question ba? Pabalik naman sa saan ba tayo? O yung sa una lang, tignan mo kung meron ba akong maitagdag. Sige. Okay naman yan. Okay naman sa definition. Ay, sa ano, doon, sa pathophysiology. Okay. Sa pathophysiology, kasi wala akong napansin na merong nabanggit dito ang brain herniation. Diba yung traumatic injury, meron ba nabanggit brain herniation dyan? Ga?
Meron po, ma'am. Sa baba po.
Asan dyan?
Dito po. Baba po ng hypotension and anemia.
Kaya pala nakatakip sa akin, pinakababa. Ayun. Okay. So, ang brain herniation is napaka-life-threatening situation. So, alamin na natin yan. Pag nagkaroon ng trauma ang brain, expect natin lalo na kapag blunt trauma. Hindi natin makikita, wala tayong makikita unless magkaroon ng CT scan result. So, hindi pa man nangyayari, dito pa lang sa primary, na lahat na ng preventive measures gagawin or ginagawa na natin to be able to stop from developing the secondary trauma. Yung secondary na, yung medyo madidelay ka sa oras doon sa mga intervention sa primary, kaya umaabot na hanggang sa secondary, wherein makikita na natin na meron na talagang brain edema. Okay? Now, the thing is, if the edema continuously increase at marami na mga walking mga electrolytes and glucose nangyayari, na nasisira na ang metabolism. Okay, ilagay natin, part na yan, na nagkakaroon ng brain herniation. Bakit brain herniation? Ibig sabihin lang yung herniation is yung sobra na nilang sikip sa loob, so nag-ano na sila, nag-deviate na sila yung way kung saan pwede pa ma-accumulate. Okay, so dahil dito, nagkakaroon ng naiipit ang brainstem natin. Okay? Alam niyo yung brainstem from the spinal cord hanggang sa dulo bago magbuo yung pinaka bilog, okay? Yun yung pinaka puno, okay? Bago yung mga dahon-dahon, yun yung pinaka brainstem. Okay, dulo ng trunk kumbaga ng spinal cord. So kapag iyan ay naiipit, delikado na. Okay, anong mga manifestations na makikita natin para masabi natin, nako, meron ng brain herniation ito. Okay, di ba ginagawa natin ang continuous GCS? Okay, so sa continuous GCS, every 15 minutes yan, kailangan lagi-lagi minomonitor neurologically. So, ang isa dyan is yung pupillary reaction. Kapag wala ng reaction ng pupils, either right or left, or yung left meron kunting reaction, ang right wala ng reaction, isa yung indication na meron ng brain herniation. Kapag nag-induce tayo ng gag reflex, okay? Tapos hindi nagkaroon ng gag reflex si patient. Ano ba ibig sabihin ng gag reflex? Anyone? Oh, uy, hindi niyo alam ang gag reflex? Yung hawakan niyo yung lalamunan, iipit niyo yung ano, tapos magaganyan siya. Yung ipit lang, oo. So, kapag wala na yung ganung reaction, ibig sabihin meron ng herniation. Another thing is, kapag ginalaw yung mata niya, pero wala, blanco lang siya, ganun. Walang blinking nangyari, isa din yun. Kapag nakita mo, parang mas malaki tong mata niya. Sa normal kasi sa GCS, di ba, meron tayo mga measure ng mata doon, ng size ng pupil. So kapag nakita mo, ay, kanina pa tong ganito, hindi na gumagalaw, hindi na nag-react sa light. O yan, isa din yan sa indication na meron nga talagang brain herniation si patient. Okay? Now, if that is the case, this is already an indication na very poor prognosis na ang mangyari kay patient kasi the patient may even have brain death or kung hindi man brain death, magkaroon siya ng permanent brain damage. Ibig sabihin, permanent neurological disability na buhay nga siya pero gulay na lang siya sa kama. Okay? So, ano ang gagawin natin para i-prevent natin mangyayari yan? So, you have mentioned all the necessary preventive measures or necessary management. Usually, nandun na yung hypertonic saline, tapos yung infusion, yung diuretics infusion, tapos yung mannitol. Kasama na yan siya lagi. Okay? And at the same time, kung makita, meron tayong ICP monitoring measurement, di ba? Meron tayong ganon. So kapag nakikita natin persistent, hindi na yan kailangan maghintay pa ng ilang oras, binaburhole na nila yung brain. The patient will be resorted to emergency surgery for burhole and then i-insert yung drain para ma-drain yung mga CSF kasi continuously talaga nag-accumulate ang CSF dyan sa brain natin. Okay? So, always para ma-prevent ang secondary, kailangan talaga gawin na ang mga necessary measures para hindi na mangyayari yun, lalo na kapag tumabot na tayo sa herniation. Okay, Docs? So, ano pa ba? Sa pharmacology, meron akong anong dahilan ng ano? Okay na yan, diuretics, anticonvulsants, sedatives, okay, barbiturate. Now, kung tutuusin, barbiturate is given as the last resort. Kung hindi effective yung mga ibang bagay para ma-sedate si patient, now dalawang bagay ang pag-sedate kay patient para ma-decrease ang oxygen demand ng katawan at the same time para ma-decrease yung activity ng katawan that can increase more intracranial pressure. Kaya pinapatulog natin si patient. But kung wala nang effective na other resort, si barbiturate na ang pinaka-last resort. Okay? Aside from sa bagay, ito naman kapag TBI, hindi naman ano, kasi ano to, addictive to. At the same time, it can even kill the patient. Okay? So, ayan si barbiturate. Keep watch nyo rin siya. Then, si magnesium. Ano ba yung, parang, ano ba ang role ni magnesium? Guys, ano yung nabanggit nyo about magnesium? Electrolytes magnesium. Ano yan?
Para po makapag-improve po siya ng blood flow po sa brain.
Okay. Yes, tama. Para makapag-improve siya ng blood flow. Bakit? Kasi mismo si magnesium is somewhat like work as synergistic effect sa mga diuretics and mannitol. Nagdi-decrease siya ng brain edema within few hours lang. So, binibigyan natin siya ng magnesium. Okay? Next, yung muscle relaxant. Okay na yan. Alam natin kung bakit. Okay? Kasi hindi natin kailangan pa-increase yung mga oxygen demand at brain activity. Kaya kailangan talaga meron silang muscle relaxant. Pain relievers. Okay na yan. Hindi na kailangan. Ano pa ba yun? So, management yung pagkain. Si Doktor yan. Doon sa inyo, sa nursing. Okay, sa nursing, okay naman yung assessment. Kailangan alam na natin. Airway management, alam na natin kapag naka-ET tube si patient. Cerebral perfusion pressure, minomonitor lang natin yan. Medication management ay yung mga medication na may nursing care na nabanggit na natin simula pa ng mods tayo hanggang ngayon. Although yung nadagdagan lang kasi dati meron na tayo about sa mga diuretics, sa chuchu, si magnesium lang talaga. So ang pinaka-role lang talaga ng magnesium dito is decrease tawag nito, ma-decrease ang pressure dahil meron siyang synergistic effect with mannitol and diuretics. Then, ICP monitoring, wound care. Now, ano ibig sabihin ng wound care? Wound ng brain kung saan nag-gain entry kung whatever ang pumasok para magkaroon ng TBI. Okay? So, as much as possible, very proximal yan sa brain. Okay? Or sa brain cells, ibig sabihin, aseptic technique lagi yan. Okay? Now, kung wala namang wound, kung meron tayong excuse me, kung blunt injury yan. But still, because of the possibility of herniation, kung makita natin may increased ICP na, binaborehole na nila yan, so yung mismong borehole is considered as wound, manage din natin as wound care, okay? Fluid and electrolyte management, alam na natin. Now, the fluid and electrolyte management is kailangan natin bantayan kapag binigyan natin siya ng nutritional support. Particularly si pasyente is para hindi ma-increase ang ICP, hindi tayo nagbibigay ng NGT, enteral nutrition. Okay? So, ang usually binibigay sa kanila is the TPN. Okay? Now, sa TPN, meron tayong mga nursing management yan kasi ang TPN mismo, it can lead to TPN-induced liver damage. Kaya before the TPN started, kailangan meron na tayong baseline na liver function test. Kapag nakita natin, normal naman lahat yan kasi TBA yan eh. May mga TBA because of road traffic accident and things like that. So normal yung mga nila, liver function test. At least baseline na natin yon. So kapag on continuous TPN siya, lagi-lagi minomonitor yan kung nai-increase ba ang mga ALT, SST, chuchuchu o hindi. Okay? Kasi ayaw natin mangyari na madadamage siya. Now, during TPN also, we also have to keep watch dahil magkakaroon ng wacky electrolyte balance. So, aside from minomonitor natin ang liver function test, minomonitor din natin ang mga electrolytes niya. Kailangan within normal limits yan. Hindi pwedeng mataas, hindi pwedeng mababa. Okay? And alam niyo naman ang implication kapag meron hyper or hyponatremia, lalo na TBI yan. Okay? Another thing is, aside from that, the TPN can also have, ano ba tawag nun? Increase teka. TPN, tapos, yung insulin niya, kumbaga mag-i-increase ang tawag nito, mag-i-increase ang demand ng mga cells, okay? Kasi marami siyang highly concentrated kasi si TPN. So keep watch also of the blood sugar. Pwede siya maging mataas na blood sugar. And check also the level of insulin. Is it concomitant to the amount of sugar the patient is receiving and things like that. Sometimes the insulin do not recognize the sugar, kaya hindi niya yan dinadala sa loob ng cells. So, close watch din natin. It's because of the highly concentrated TPN. Now, TPN, usually, it is done aseptically in the pharmacy under a laminar flow hood. Ibig sabihin, alam niyo yung laminar flow hood? Yung saan nagmi-mix yung mga gamot-gamot na yan, parang incubator, tapos ang pumapasok lang dyan ay yung mga kamay, yung incubator na may gloves. na yun, yung sa gloves ka lang gumagalaw. So, paano mo ipasok yung mga items niyan? So, it is a sterile items na kapag binuksan mo, kailangan careful pagpasok mo sa loob dahil para wala tayo maipasok ng mga pathogens yan. Yung sa may pintuan naman ng laminar flow hood, ano yan, parang may hangin palabas para pag i-introduce mo yung items na gagamitin mo pang mixture, magpupush yung mga hangin palabas. So, ibig sabihin, walang entry mangyayari yung mga pathogens na yan. And it is done very aseptically. Hindi tayo ang gumagawa. So, if for example, there is an order of TPN by the doctor, you just have to set the requisition sa pharmacy and then wait until it is ready. So, TPN is different from osteorized feeding, wherein we have the osteorized feeding given by NG tube. Okay? Yung osteorize, yung parang shake na itlog, yung mga ganyan. Pero sa amin, hindi na talaga uso yung osteorize. Ang binibigay namin sa mga pasyente yung highly nutritious na Ensure. Yun, maganda yun sa NGT. Pero TPN, sa lang talaga yan. Kasi meron talagang proper measurement ng mga ingredients niyan doon sa pharmacy. Okay, so talking about seizure management, meron siyang anticonvulsant medication. Positioning and mobility, alam natin na itong mga pasyente na to hindi basta-basta pwedeng iikot kundi log rolling lang. Okay, log rolling yan all the time. Okay, then sa seizure management, usually, sa amin, nilalagay namin ang precaution. Nilalagay namin sa file ni patient. Yung cover ng file, nakalagay talaga doon, naka-indicate na sticker, seizure precaution. Okay? So, tapos sa bedside naman, meron siyang file dyan, o mga TPR file, nilalagay namin doon, seizure precaution. So, ano ibig sabihin ng seizure precaution? Ibig sabihin nun, you really have to make sure na readily available ang emergency drugs to prevent the seizure. Kasi kapag ang seizure is uncontrolled na, matagal, kailangan na natin bigyan ng value or any IV medications. Kasi kung hindi, madadamage ang mga brain cells. Okay? So, ayan, seizure management. Family and patient support, nasabi ko na rehabilitation. Now, if the patient is recovered, marami din yan mga prosesong gagawin para sa rehabilitation. Okay, so depende kung ano yung mga manifestations na pakita niya sa during rehabilitations na pwede pang agapan, ayan na, pwede na yan. So kung nag-stroke siya, kasi stroke talaga yan, nag-stroke siya, pwede siya i-resort sa speech therapies, pwede siya i-resort sa yung mga movements sa physiotherapies, mga ganun-ganun bagay. And of course, your documentation. So again, huwag kalimutan, ang documentation ng mga nurses should be precisely accurate. Short nga siya, pero it gives you the big picture of everything. So practice doing that. Okay? Ito yung tinatawag natin na word economy. Okay, so kung walang question, move on to the next topic. Okay, Rachel, bakit?
Curious lang, ma'am. Kailan po ina-announce ng doktor na brain dead na po yung patient?
Kapag hindi na siya nagre-respond sa mga kapag continuous ang intracranial pressure, tapos continuous yung aeration, gumagrabe na, dilated na, malaki na ang pupil niya, tapos hindi na niya kaya kung walang respirator, brain dead na yan. So, hindi naman pwedeng tanggalin ang respirator. So, monitor yan. Walking na din yung mga ang mga electrolytes niya, tsaka yung mga results niya, walking na din. But still, nabubuhay lang siya sa respirator. Ayan, brain dead yan. Meron kaming pasyenteng ganyan sa ICU. O dumating siya sa ICU ng 7 years old. Umabot siya ng hanggang 12 years old na gulay, na alam niyo naman sa Middle East, ang Muslim kasi naniniwala sila habang may signs of buhay pa, Hindi mo pwede yung sinasabing tanggalin na kasi wala na yan, gulay na yan. Hindi pwede sa kanilang ganyan. Habang may chance pa of buhay, talagang ginagawa lahat ng paraan para ma-maintain ang, kumbaga, buhay pa yan eh. Bakit hindi mo Kasi if you deprive them from oxygen and TPN and things like that, as if you are already killing them. And that is that they do not like because they know and they believe that it's only God who can kill the buhay of the people. Okay, so continue siya. Hanggang sa pag-alis ko doon, nandun pa rin siya sa ICU. Malaki na siya. Dati pediatric bed lang siya. Ngayon talagang adult bed na. Yung bago ako umalis, adult bed na ang ginamit niya. Okay? Pero brain dead na siya. So, paano yan, ma'am? Sobrang mahal naman ng bayad noon. Gobyerno naman yun eh. Walang problema. Alam mo naman ang Middle East, mayaman yan. Ayun. O, sige na. Next topic na.
Rinig po ako, ma'am. Good day po, ma'am and classmates. We are the last group and we are going to discuss yung last topic for our report, which is yung spinal cord injury. Our members po are si Joanna Faye Bagtas, Mark Bastasa, Janine Francine Cruto, Mark Angelo Iglesia, Johan Vianli Mariano, Kiara Olgado, and Ivan Guyver Paulino. So first, going back to our anatomy, the spinal cord is the crucial part of the central nervous system. It is a long, thin, cylindrical structure that extends from the base of the brain through the vertebral column. So this is our spinal cord. There is 5 segments po. So the cervical supports the head and the neck. The thoracic naman supports the ribs. Yung lumbar supports, moves, and bears yung weight ng katawan natin. Tapos yung sacral stabilizes and bears the weight of our body. Yung sacral po, nagsastabilize and nagko-connect yung spine sa pelvis natin. And the coccyx naman po supports the muscles and assist in balancing kapag umuupo po tayo. There's a famous mnemonic po that helps us remember yung major spinal cord segments, which is yung 7 a.m. for breakfast, which is C1 to C7. Then yung 12 p.m. for lunch, which is T1 to T12. Then yung 5 p.m. for a light dinner, that is L1 to L5. So now that we understand the parts of the spinal cord, we can now understand further kung ano po yung spinal cord injury, which is yung damage or trauma to the spinal cord that results in loss of impaired function, causing reduced mobility or sensation. With that, there are 2 types of spinal cord injuries. There is the complete spinal cord injury and the incomplete spinal cord injury. Yung difference po ng dalawa is that in the complete spinal cord injury, it leads to permanent damage wherever the affected area is. Whereas the incomplete naman po refers to partial damage lang. So here are the types and levels po of the incomplete spinal cord injury. Yung first one is yung central cord syndrome. This happens in the middle part po ng spinal cord. It often results from hyperextension injuries of the cervical neck region. This usually causes more problems in the arms than kesa sa legs. And sensation and movement below the injury level may be affected. Tapos yung anterior cord syndrome naman po, it happens in the front part of the spinal cord and it results from various reasons kagaya po ng tumor compression or yung vascular problems. Ito naman po, this leads to a loss of movement, pain, and feeling the temperature below yung injury. Then yung some sensations po like body position and vibrations can still be felt. Yung last po, which is the lateral cord syndrome or the Brown-Séquard syndrome. This is considered rare daw po kasi this is where the side part of the spinal cord is harmed. Like bawat either left or right po. And It can happen due to same reasons din po, kagaya ng tumors or yung blood flow problems. Sa syndrome in this syndrome, there may be a loss of specific sensory and motor functions depending sa level down ng injury. And typically, motor function, proprioception, and vibration senses are preserved, while pain and temperature sensation may be impaired on the same side of the injury. Next po is the type and levels of the complete spinal cord injury naman po. In the paraplegia naman po, this is the paralysis starting from the thoracic to the sacral area, which only affects the legs. In the tetraplegia naman po, it is also known as quadriplegia. It is the paralysis sa cervical area, which is affecting both arms and legs. Next po.
So, for assessment and characteristic naman po. Next slide, please. Next slide po. Ayun, we have flexion rotation injury, flexion injury, compression injury, and hyperextension injury. So, in flexion rotation injury, the flexion rotation injuries involve a combination of forward bending and twisting of the spinal column. Then yung mechanism niya po is yung injury pong ito is nakaka-occur siya nakukuha siya in incidents like sports related tackles where a person body is rotated while being bent forward. Then, the combination of flexion and rotation can result in complex spinal cord injuries affecting various parts of the cord and potentially causing extensive damage. So, yung sunod naman po is yung flexion injury. Sa flexion injury naman po is yung head and upper body are forcibly bent forward, typically in a downward motion. So this can occur in a various situation such as motor vehicle accident where the front end of the vehicle collides with an obstacle causing the head and neck to flex forward rapidly. Then yung flexion injuries po often after the interior or in the front portion of the spinal cord and can result in compression or contusion of the cord tissue. So this can lead to motor and sensory deficit po. Then, yung sunod naman po is yung compression injury. It occurs when an external force compression or crush the spinal column. Then this can result from incidents like falls from high where the spine is subjected to a strong downward force. Then compression injuries can lead to various types of spinal cord damage, including fractures, dislocations, and compression of the cord itself. Then the next of the injury depends on the force and duration of compression. Then next po is yung hyperextension injury. Hyperextension occurs when the head and upper body are bent backward beyond their normal range of motion. Then it can happen in incident like whiplash injury during a car accident where the head is forcefully thrown backward. Then yung hyperextension injuries po often impact the posterior or yung back part of the spinal cord. These injuries can lead to damage to the ligament bones and spinal cord itself. So, kung yung flexion injury is sa front, yung hyperextension naman po is patalikod. Next slide po. So, we have an assessment here, the International Standard for Neurological Classification of Spinal Cord Injury or ISNCSCI. So, ginagamit po ito para ma-define yung level ng sensory and motor impairment after a spinal cord injury. Then, ginagamit din po ito to assess the extent of the injury. At pwede rin po siya gamitin to monitor the rehabilitation po. Next slide po. So, meron po kaming example dito. Yung example scenario po namin is si patient exhibit normal bilateral light touch in left and right down to C6. Then, normal L pinprick sensation down to C6. Then po, yung sa left. Then, normal right pinprick sensation to C7. Then, yung sensation absent elsewhere po. So, yung elbow daw po extension, yung elbow extension po sa right is 5, then sa left po 5. Sa finger flexors naman po, yung 3 po sa right, then 3 rin po sa left. Then sa finger abductors naman po, 3 po sa right, then sa left po 0. Then yung VAC nila and DAP or yung voluntary anal contraction or deep anal pressure is no. So paano natin siya ilalagay sa assessment natin? So, ganito po yan. Dun sa, yung dun po sa sensory part, makikita natin na marami siyang box. Then sa gilid is may C2 hanggang S4 to 5. So, sensory po yan. Yung scoring po dyan, kapag 1 po is altered sensation. Kapag 2 po is normal sensation. Then kapag 0 po is absent sensory po siya. Then, ang itatanong natin, ang mahalagang itatanong po kay patient is kung sharp or dull and does this feel the same as your face? Ayun, yun po yung dalawang mahalagang itatanong kay patient kapag nag-a-assess po ng pinprick sa light touch scoring. So, ang sabi nga po sa natin, sa example natin kanina is yung left pinprick daw po, sensation down to C6, nasa C6. Bali, normal po yung pag normal, di ba, 2, bali, nilagay natin na 2 hanggang dun sa C6. Then, dun naman po tayo sa right. Ang sabi naman po sa right natin is yung light touch daw po hanggang C6 yung normal. Bali, normal natin is 2. Hanggang dun po yung ilalagay nating 2. Then, pagdating naman po sa pinprick, since sabi sa C7 is, sa C7 yung normal. Bali, hanggang C7 po ilalagay is yung number 2. Then, pupunta po tayo sa babang part, sa neurological level, dun sa sensory. Then, ilalagay dito kung ang level is yung both na pinprick na light touch sa left and right. Ayan, ilalagay natin doon. Bali, for example, yung sa C7, may number 2 doon sa pinakababa. Yun kasi yung the rest po dyan is 0 na. Bali sa C7, kung makikita nyo po, may number 2 doon. Since yung light touch is 0 siya, hindi natin pwedeng ilagay yung C7. Dapat parehas sila. Bali sa C6 natin, si C6 yung ilalagay natin. Since parehas silang may score. Same din po dun sa left side. Then, sa motor naman po tayo. So, yung lowest level po, at least 3 and 4. Kapag sa motor naman po is meron tayong C5 to T1. Same po ulit sa left and right. So, based ulit sa example natin, yung elbow extension is 5 yung score niya sa right, then 5 din yung sa left. Ayun. So, ang scoring po kasi dito, kapag 0 po siya is total paralysis siya. Bali, yung muscle is completely flaccid. Then, kapag 1 naman po is palpable or visible contraction. Then, kapag number 2 naman po is yung active movement, gravity eliminated. Then, kapag 3 naman po, may active movement siya. Then, nag-a-against din po siya sa gravity. Then, yung number 4 naman po is yung active movement against some resistance. Then, number 5 naman po is yung active movement against full resistance. Then, meron din po tayong NT or not testable. Then, hindi po ginagamit lang po ito kapag kapag meron pong missing limb or for other reason that make assessment, impossible po. So, balik naman po tayo sa motor, yung scoring. Since yung sa example po natin is yung right nga po is 5, then sa left po is 5. Ilalagay po natin doon sa yung elbow extension is 5. Ayan, nakalagay naman po. Then, sa finger flexion po is 3 naman po, yung right, then yung left din. Then, dun naman po sa finger abductors, yung right po is 3, then sa left naman po is 0. Balik ulit tayo dun sa neurological levels, dun sa motor. Hindi tayo pwedeng maglagay ng T1 sa motor kasi kailangan parehas sila ulit. Parehas yung left and right na score. Ang parehas lang dyan is yung C8. Ayan, C8. Kaya C8 yung nandoon. So, for neurological level of injury, makikita natin kung ano yung level ng neurological sa pamamagitan ng level of sensory and motor. Then, ipipick natin yung pinaka-highest or pinaka-mataas na level na malapit sa spinal cord. So, mas nasa taas yung C6 kesa sa C8. So, ang ilalagay natin doon si C6. Then, complete or incomplete, complete lang siya kapag si VAC and DAP ay naka-no, saka yung S4 and S5 niya ay 0. Since, ang sabi nga po sa example natin kanina is yung VAC saka yung DAP is no, then sensation absent elsewhere. So, yung S4 to S5, 0 din po. Bali, complete po siya. Then, sa Asia impairment naman po, kapag complete spinal cord po, ang ilalagay natin is A. Then kapag incomplete, pwedeng ilagay si B, C, D, or E. So, kapag malalaman nating B siya, kapag incomplete siya, saka no motor sensory. Then, sa C naman po, masasabi nating incomplete kapag yung 50% of muscle less than grade na 3. So, or hindi niya kaya i-raise yung arms niya or yung legs niya. Then, yung D naman po is incomplete po siya na 50% of muscle more than grade na 3. So, yung dito naman po is kayang i-raise ni patient yung arm niya saka yung legs niya. So, yung E naman po is normal motor and sensory function are normal po. Ayun. So, si pasyente natin dito sa example is puro no yung VAC niya sa DAC, saka 0 din yung S4, saka yung S4 to S5 niya, then complete siya, bali A yung lalagay dapat natin dyan. Then yung sa zone of partial perversion, nilalagyan lang to kapag complete injury. Then ilalagay dito yung furthest level na may score dito. So, kunwari, sa sensory kanina, sa right side, yung farthest po dyan, di ba, C7? Kung yung sa kaninang sensory is dapat both silang parehas, yung dito naman po, yung farthest lang. Kahit hindi po sila parehas, bali, sa right side is yung C7, then yung sa left side naman po is yung C6. Same din po yung dun sa motor. Sa motor naman po is yung T1. Since sa right side po, nakikita nyo may 3 po dun sa T1. Then, sa left side naman po is sa C8. Ayun. Next reporter po.
Okay, sige.
Hello rin po. So, then for the diagnosis po, we have X-rays or lateral spine X-ray. Itong X-ray nito is taken from the side. So, yung radiologist yung kukuha dito para ma-evaluate yung vertebrae. So, this test is non-invasive naman and hindi rin siya masakit. So, ang gagawin mo lang is hihiga ka lang din bahala na yung radiology tech na gumawa para makakuha ng good image. Next is yung CT scan po. So, dito, pinapakita yung detailed na image ng any part of the body po, including bones, muscles, organs, and blood vessels. So, ayun. Next is MRI scans. So, itong MRI is parang secondary lang ng CT scan. So, ang ginagawa dito is to investigate or ina-diagnose yung conditions na nakapag affect ng soft tissue sa spinal or kung saan man yan. So, itong usually kasi yung CT scan or ito yung first choice for imaging. So, kapag may hindi siya na pag hindi nakuha ng CT scan, dun na papasok si MRI para para sa specific na location tsaka pang-detect din sa kung saan man yung may problema. Kaya pangalawa yung MRI. Next is myelogram po. Ito yung para mahanap yung mga problema sa spinal canal. Example, problems yung mga nagde-develop sa spinal cord, sa nerves, nerve roots or other tissues po ng spinal cord. Next is we have electrocardiographic monitoring. So, bakit nga ba may ECG monitoring? Since may spinal cord injury yung patient, mas dito, mas common, kaya may ECG monitoring kasi baka may makikitang bradycardia since common ito sa mga patients na may spinal cord injury po. Next is somatosensory evoked potentials or SSEP. Ito yung test na ginagawa para ma-investigate yung function ng mga nerve pathway between sa limb. For example, yung arm or leg. Pati na rin din yung brain through spinal cord. So, ginagawa ito by stimulating hand or foot using electrical impulses. And then, record yung responses from the nerves. Next is CBC. So, natin to. LBC, RBC, platelets, yung yun. Last is arterial blood gas, which is ABG. Ginagawa ito para ma-evaluate yung adequacy of oxygenation and ventilation. Ginagamit din ito para sa screening tool among patients para patient na sustaining trauma for occult injury po. Next reporter.
So, for the etiology naman po, meron po, dito po is pumapasok yung traumatic injuries. So, dito po sa traumatic injuries, first po is yung motor vehicle crashes. So, during a crash, the force can cause hyperflexion, hyperextension, or compression of the spine. Naglilid po to dun sa fractures or dislocation ng spinal cord damage. Next po is yung falls. So, dito, falls from heights or sleep can lead to abrupt loading of the spine. So, dito po is nag-result po to ng compression fractures, vertebral dislocation or spinal cord injury, depending po dun sa force or angle ng impact. Next po is yung violence or yung predominantly gunshot wounds. Dito po is yung gunshot wounds can lead directly damage doon sa spinal cord nearby sa structures. So yung bullet can cause yung spinal cord transection or yung contusion or yung hemorrhage. Nag-lead po ito sa spinal cord injury and neurological defects. Next po is yung sport-related injuries. So dito po is high impact sports can lead to spinal injuries such as yung fractures, inherited disc or spinal cord contusion, forceful tackles o yung collision. Or yung cause ng ito po is magkukause ng damage doon sa spinal cord. Next po is yung alcohol and substance abuse. So, siyempre, pag alcohol and substance abuse medyo high, ano po to, magiging lead po ng siguro ng falls o ganon, which can result dun sa spinal cord injury. Next naman po is yung sa non-traumatic injuries. So, dito po is yung medical condition. So, sa medical condition, dito po pumapasok yung cancer, spinal tumors, multiple sclerosis, and transverse myelitis. Then, sa second naman po is yung infection. So, dito po sa infection, dito po naman po papasok spinal cord, epidural abscess, meningitis, or polio. So, sa last naman po is number 3, vascular disorders. Dito naman po papasok yung infarction or yung arteriovenous malformation can disrupt yung blood flow or yung spinal cord. Nagre-result po sa injury. So, dito po sa medical, yung first po is sa cancer. Dito na sa cancer po is can spread po yung bones, including po yung vertebrae or the spine. When a cancer is metamizes or the spine, it can weaken the bone structure or making a more susceptible to spinal cord or nerves, causing to spinal cord injury or nerve compression. Then, sa spinal tumors naman po, yung ito po is magko-compress dun sa spinal cord or nerve roots leading to neurological defects and spinal injury. So yung tumor growth can also weaken the surroundings of bones, increase yung risk ng fractures or spinal cord damage. Then sa sclerosis and transverse myelitis, dito po yung multiple sclerosis can cause yung demyelination or yung inflammation of the spinal cord. Maglilid po ito doon sa disruption in the nerve signaling, and this can result po yung symptoms like weakness, numbness, or loss or condition, potentially causing the spinal injury over time. Then dito na sa infection po is yung spinal cord epidural abscess. Dito po yung sa spinal epidural abscess, yung abscess can compress the spinal cord and impede blood flow, resulting in spinal cord injury. Additionally, yung infection-related inflammation can contribute to the damage of spinal cord tissue. So, sa meningitis po is yung an infection to membranes or meningitis that protect the spinal cord and brain. When the membranes become infected, they swell and arrest the spinal cord or brain. Then sa polio naman po, it can directly affect yung or mag-destroy yung motor neurons in the spinal cord. Maglilid doon sa muscle weakness and paralysis. Over time, yung muscle atrophy po and yung contractures can yung contribute to ng spinal cord injuries. Then sa vascular disorders, first po is yung spinal cord infarction. So dito po is typically occurs when the blood vessels that supply the spinal cord become occluded or narrow. This can result from conditions like yung atherosclerosis or yung light or yung blood clots. Nagre-reduce yung blood flow, deprived sa spinal cord or oxygen and nutrients. Maglilid po ito sa tissue death and infarction or as a result doon sa neurological effects and spinal injury. Last po is yung atherosclerosis malformation. Dito po yung congenital abnormalities in which arteries and veins are normal connection or yung tangles. Blood flow in AVMS can be turbulent leading to increased pressure in the blood vessels. Over time, this can cause damage or surrounding spinal tissue. AMS may rupture or hemorrhage leading to bleeding to spinal cord and subsequent injury. Yun lang po, next reporter po.
Rinig po ako.
Yes, rinig ka.
Thank you po. So, before we dive into the pathology of our SCI, let's first define yung two categories of SCI, which is the primary injury. Primary injury is the result of the initial insult or trauma. So, ito yung pinaka-una or pinaka-initial na nangyayari or na-feel ng katawan ng patient right after ng trauma or right after ng impact of the mechanical force doon sa ating spinal cord. It also disrupts axon, blood vessels, and cell membranes. I will be explaining this later. The second category is secondary injury. So this happens after primary injury. Nangyayari siya minutes to months following doon sa initial impact. This is characterized by vascular damage, ion imbalance, and excessive toxicity, free radical formation, calcium influx, inflammation, cell death, and scar formation. So damage in SCI or spinal cord injury ranges from transient concussion to concussion. Transient concussion meaning parang short-term brain injury. Tapos concussion is bruising, laceration and compression of spinal cord tissue, complete transection of spinal cord. Yung complete transection can also be coined as complete spinal cord injury, meaning anything below the level of the injury is paralyzed na. Next is primary injury, and then yung secondary injury. Yung result nun could lead to complications, either paraplegia or quadriplegia, depending dun sa kung saan part or segment ng spinal cord na hit or nagkaroon ng injury. So paraplegia, meaning both legs or yung lower extremities is may damage. Yung quadriplegia naman is all the limbs. So both arms and both legs yung may damage. So dito na po tayo sa web chart. So pinakauna sa pathology is of course yung etiology or yung cause, which is mechanical damage. Kasi usually naman, most often than not, yung cause ng spinal cord injury is mechanical damage. Like for example, car accidents, sharp or blunt trauma, or mga firearms, ganun. After that is the primary injury. So, dito muna tayo sa increase of intracellular calcium concentration. This happens kapag nagkakaroon ng damage yung cell membrane na cells or yung pinaka-skin ng cells. So, kapag nagkaroon ng damage, nagkakaroon ng opening, tapos doon nakakapasok or naglilik in yung mga calcium ion na nakatambay sa labas ng cells natin. And then when that happens, nagkakaroon ng build-up or influx ng calcium ion doon sa loob ng ating cells. So that's why nagkakaroon ng increased calcium concentration doon sa loob ng cells. Next is the free radical production. Yung free radicals are molecules that are very unstable and highly reactive. Natutukoy yung molecule as free radical kapag they have unpaired electron. So, yung mga free radical na produce siya kapag nasa-stress yung cells or nadadamage sila. So, natural response yun ng cells kapag nasa-stress sila, nag-release sila ng free radical. And what they do is that since nga they are unstable and highly reactive, they tend to harm yung mga nearby na healthy cells, causing further damage. Next is massive ionic influx. This is the parang same thought with the increased intracellular calcium concentration, because in the context of our SCI, yung kapag ionic influx, doon tayo nag-focus sa calcium ion. So nagkakaroon ng build-up or influx doon sa loob ng cells. Sumunod is increase of glucose transporter 1 or our GLUT1. So
self-explanatory yung name niya, nagta-transport siya ng glucose doon sa damaged area. Glucose equals to energy. So ibig sabihin, nagta-transport ng energy doon sa affected area to help with the recovery process. Next is release of VEGF and NO. Ito si VEGF and NO, they work hand in hand. Si VEGF stands for vascular endothelial growth factor, and si NO naman is nitric oxide. So, nag-work sila how? Yung VEGF kasi, syempre kapag may damage, nasisira yung mga blood vessels. Si VEGF is responsible for creating or forming new blood vessels doon sa affected part. And then si NO naman, si nitric oxide, responsible siya for dilating those blood vessels to promote blood flow. Para syempre it's important kasi yung blood flow andun yung mga oxygen and nutrients that also helps with the recovery process. Next is the disruption of our BSCB or blood spinal cord barrier. So again, self-explanatory yung kanyang name. Literal barrier siya, physical barrier that separates blood and the spinal cord. Pero it doesn't mean na walang blood doon sa spinal cord. It means na ano siya, yung pinaka-function niya is to be a selective barrier. Nakakapasok pa din yung blood sa spinal cord through capillaries and blood vessels, pero nasa-select lang yung kung sino lang yung nakakapasok kasi our blood have pathogens and toxins, and yun yung iniiwasan ng BSCB na makapasok sa ating spinal cord. So yung disruption of blood spinal cord barrier is simply may na-damage yung barrier na yon, yung physical barrier na yon. Then that would lead to hypoperfusion of the gray matter. So bakit may hypoperfusion or low blood na nasira na nga yung barrier, ibig sabihin free na pumasok yung blood sa loob ng ating spinal cord. Nagkakaroon ng low blood flow kasi yung mga nakakapasok, kasama na dun yung mga pathogens and toxins. Kapag nakapasok yun sa spinal cord, it triggers inflammation. And inflammation, nandun na yung swelling, yung compression, which constricts our blood vessels. Kapag there is constriction of blood vessels, limited na yung yung blood flow tsaka yung mga oxygen na nakakapasok. That's why nagkakaroon ng hypoperfusion of the gray matter. Next, let's go to the secondary. Yung gray matter pala is yung pinaka-inside ng ating spinal cord. It's a type of tissue found in the spinal cord and brain. So, ayan. Let's go to the secondary injury. Next, under secondary injury, vascular ischemia first. Vascular ischemia happens kapag yung blood supply to the spinal cord is further reduced or cut off. Nangyayari siya kapag, of course, may inflammation. Sinabi ko kanina na may swelling and compression. And also, kapag nagkakaroon ng blood clot. Yung blood clot na-form siya kapag nadadamage yung ating blood vessels. Kapag nagkaroon ng vascular ischemia, after that is yung apoptosis and necrosis. Yung apoptosis and necrosis are both scientific terms that refers to cell death. Ano yung difference nilang dalawa? Yung apoptosis is controlled death, while yung necrosis is uncontrolled death. Yung apoptosis is yung nakaprogram na siya mismo sa cell. So, tawag dito, yung cells, they actively participate in their own death. So, para siyang suicide. Yung necrosis naman, this happens due to external factors, like for example, damage or injury, which is in the context of our SCI. Next is microglia and caspase activation. So ano ba tong dalawa na to? Yung microglia, na-activate siya kapag may nasisense siya na may damaged cells or may dying cells. So saka siya na-activate. Kapag yung microglia, yung function niya is to be para siyang clean up crew. So siya yung nagre-remove ng mga damaged or dead cells. Pero while doing so, habang naglilinis sila, may nare-release sila na substance that is that can be harmful to our spinal cord, which is yung ating mga cytokines. Ayan. Mga cytokines. We learned from previous discussion that cytokines play a role in the inflammation process. So since
marami na yung namamatay or nag-undergo ng apoptosis, marami na yung na-activate na microglia, so marami silang nalilinis, marami din yung nare-release na cytokines, which makes the inflammation process grabe or severe. Yung caspase naman, these are types of enzymes that gets activated on the onset of apoptosis. Yung apoptosis naman, siya, parang, since di ba sinabi ko, programmed siya, may step-by-step process before matapos yung apoptosis. The start or onset ng apoptosis, na-activate na agad si caspase. Yung nare-release is two different types of caspases. Isa is pro-apoptotic. So, ibig sabihin, it promotes programmed cell death, and nagre-release din ng type of caspase na pro-inflammatory. So, pro-apoptotic and pro-inflammatory, meaning they promote cell death and they also promote inflammation. Which is nagiging grabe na yung inflammation natin kasi may microglia pa nga. Next is electrolyte disorder. So bakit mayroong electrolyte disorder sa secondary injury phase ng ating SCI? Our electrolytes, for example, sodium, potassium, calcium, and magnesium, crucial sila in maintaining the balance of fluid in our body. So kapag may injury, yung distribution ng mga electrolytes na to gets disrupted as well. Ayun. Yun yung pinaka-main point why there is an electrolyte disorder. After that is the release of NO and glutamate. Sinabi ko kanina, the NO or nitric oxide is responsible for dilating the blood vessels. Pero excessive amount of NO being released, na-overdilate yung mga blood vessels, which promotes unregulated blood flow. Kasama na din doon yung mga electrolytes na nadidistribute, nagiging unregulated na din sila. Glutamate, release of glutamate. Our glutamates naman are neurotransmitter. Ginagamit sila to help in communication or sending signals. Yung kapag there is damage or injury, yung mga cells na damage, they release glutamate. So they send signals sa mga neurons na there is something wrong here. So ayan, since marami na yung nadadamage, marami din yung nare-release na glutamate. Yung nangyayari is nagkakaroon ng sensitivity ang mga neurons sa glutamate. Kapag nangyari yon, napopromote yung yung cell death. Mas lalong napopromote yung cell death. This process, yung hypersensitivity ng mga neurons sa glutamate, this is a process called excitotoxicity. So after excitotoxicity is the inflammatory reaction. Since nagkakaroon ng mga cell death, may inflammation. Itong si IL-1 alpha and IL-1 beta, these are types of cytokines. Tapos ito naman si MCP1, GROKC, tapos si MIP1 alpha, these are types of chemokines. Itong sila cytokines, we've learned na sila ay signaling molecules. They send signal na there is a problem and they send help. Tapos ito namang mga chemokines na to, sila ang nag-serve as parang lighthouse or parang beacon doon mismo sa damage area. They attract yung immune cells para alam ng mga immune cells kung saan sila pupunta. So that's the relationship. Yung gliosis of astrocytes naman, yung gliosis is a term meaning reactive process siya that happens in our central nervous system. So that includes the brain and the spinal cord. Kapag na-activate yung process na to, they release astrocytes. Yung mga astrocytes, they are responsible for creating scars doon sa damage area. Now, generally, maganda kasi yung scars na ginagawa ng astrocytes, they serve as yung barrier kasi nga nasira yung ating BSCB or yung blood spinal cord barrier. Sila yung nagiging barrier doon sa damage area. But sa secondary injury phase, nagiging sagabal siya in the recovery process kasi nagpo-form na siya ng scar, hindi pa tapos yung pag-recover. Next is
free radical production. Like I've said earlier, yung free radicals are unstable and highly reactive molecules that have an unpaired electrons. Yun yung meaning niya. Yung ROS naman na formation, ROS is reactive oxygen species. So, again, self-explanatory yung kanyang name. Mga oxygen species siya na very reactive. Example nito is sila superoxide, or yung chemical formula nila is O2 negative, si hydroxyl or OH negative, then si hydrogen peroxide, si H2O2. Yan yung mga ROS formation. Yan yung mga ROS. So na-form sila dito sa sa kasama ng mga free radicals sa process ng free radical production. What they do, since they are unstable nga and reactive, is that they take electrons from other molecules. Kasi nga may unpaired sila na electron. In the process, they damage those molecules na pinagkukuhanan nila ng electron. Tapos it sets off a chain reaction. Kasi yung mga pinagkuhanan nila ng electron, kumukuha din ng electron sa ibang molecules, tapos nadadamage na naman yung mga molecules na kinuhanan. Yung process na yon of taking electron and damaging molecules causes oxidative stress. Oxidative stress naman, in simple terms, is that marami na yung napoproduce na ROS, and then marami na yung damage na na-accumulate nila sa body, tas yung katawan natin is unable to keep up na with neutralizing ROS and yung damage na ginagawa nila. Next reporter po.
So, next po natin is yung our pharmacologic therapy. So, para sa pharmacologic therapy natin for spinal cord injury, we have IV corticosteroids. One example is yung methylprednisolone. So, it is actually administered shortly after an acute spinal cord injury to reduce inflammation and para ma-minimize yung damage to the spinal cord. However, giving anti-inflammatory or yung mga steroidal immunosuppressants para sa spinal cord injury is a bit controversial because it has shown more evidence of harm rather than benefit. So according sa mga studies daw, it increases the risk for pneumonia, mga respiratory complications, gastrointestinal complications, and merong increased risk for wound infection. Pwede rin daw magkaroon ng muscle atrophy and hypertension. So, yung use ng IV corticosteroids for spinal cord injury is a subject to debate dahil nga sa potential na side effects nito. And yung use nga is usually made on case-to-case basis, usually given only after yung initial na trauma to minimize damage, tapos controlled na yung dosage nga. Before, usually binibigay siya agad after ng spinal cord injury. Ngayon, after ng studies, hindi siya gaano. So, ang pwedeng nursing interventions natin dito or mga nursing indications is yung ABC natin, yung airway, breathing, and circulation. Dahil nga high risk siya for respiratory complications. And of course, yung sa vital signs natin, specifically yung blood pressure, since pagbibigay ng IV corticosteroids or ng methylprednisolone is nakaka-affect siya na pwede tayong magkaroon ng hypertension. Another, yung next po is yung anticholinergic. So, ang example naman nito is yung oxybutynin, tolterodine, fesoterodine. So, ito naman yung mga nag-help na ma-reduce yung effects ng problem sa involuntary bowel or yung mga bladder movements. Dahil nga, after ng spinal cord injury, yung transmission of messages between sa body and the brain is disrupted. So yung anticholinergic, it blocks the transmission signals that cause involuntary muscle contractions. Ang side effects lang nito includes dizziness, decrease in blood pressure, and sedation. So of course, again, ang nursing interventions natin or yung indications nga is vital signs monitoring, and then yung monitoring for risk, very commonly yung risk for falls, and always included usually sa spinal cord injury is nakikipag-collaborate tayo with the physical therapist dahil included dito yung mga PT exercises. So, itong anticholinergic, so muscle relaxant siya, can be administered orally through injection and others. So, ang next po, another pharmacologic therapy is yung mga antibiotics natin. So, for patients with spinal cord injury nga, have higher risk for respiratory infections. Thus, antibiotics are given. So, ang examples nito is yung mga macrolides, o mga azithromycin, erythromycin, ang mga penicillin antibiotics, mga amoxicillin, and more depending on the type of infection. So, because patients with spinal cord injury have lower lung capacity nga due to paralysis na rin and weakness of the major breathing muscles, yung poor na functioning ng ano natin can cause it to struggle in clearing secretion sa lungs. Kaya nagkakaroon ng higher risk for infections like pneumonia. So again, yung indications ito, yung mga interventions natin is monitoring nga nung airway breathing and circulation natin. Next is yung for our, meron din tayo mga anticonvulsants. So, example is yung gabapentin. So, gabapentin can help spinal cord injury patients to manage yung neuropathic pain na dahil sa damage nga sa nerves, which can affect the excitability of pain signals or yung sa seizures. So, anticonvulsants, yung nasusurpress nito yung parang overactive na transmission ng signals sa may injury and mape-prevent din ito yung further damage on the cells. So, common side effects nito is yung fatigue, dizziness, and loss of coordination. Next slide, please.
So, for medical management, yung goal po ng medical management natin is ma-prevent yung secondary injury and to observe also yung symptoms ng progressive neurologic deficit and further complication po. So, for surgical management, when it comes to this, yung compression ng, kailangan natin tingnan yung compression, when it comes to spinal injury, meron tayong certain situation na kailangan natin is surgery and these are the main reasons po. First is kapag compress yung cord kasi kapag yung spinal cord natin nagkaroon ng pressure, meaning something is squeezing. So, surgery is often necessary. Second na reason is fragmented or unstable yung vertebral body ng spinal cord natin. Kasi, yung mga bones sa spinal cord natin ay kapag nasira ito at na broken into pieces or either hindi nag-hold well together sila, surgery might be required. Third, wound penetrating the cord. So, if there's a cut or injury that goes through yung protective layer around the spinal cord natin, surgery is the best way to fix it po. Fourth reason is bony fragments in the spinal canal. So, if there's a bit of bone inside the space where the spinal cord is, so surgery is needed para ma-remove yung bits of bone na yon. And lastly, kapag nade-deteriorate na yung neurologic status ng patient natin, kasi nagwo-worsen yung condition ng patient natin, especially in terms of nervous system, surgery might be necessary para ma-prevent yung further damage. So, next slide. So, it is important din po para na manote natin na having surgery, early surgery after injury can lead to better result. So, magbibigay lang po, ang non-surgical management, magbibigay lang po pala ako ng examples ng 3 common spinal surgeries natin. So, first, yung spinal fusion, decompressive surgery, and laminectomy. So, sa spinal fusion, sinestabilize niya yung spine natin by fusing damaged vertebrae using yung screws, rod, and bones grafts. While yung decompressive surgery natin, nire-relieves niya yung spinal cords and nerve pressure by removing yung compressive elements like yung bone fragments or disc natin. And lastly, yung laminectomy, nagka-create tayo doon ng space sa spinal canal by removing the back part of vertebra or the lamina para mag-ease yung pressure sa spinal cords and nerves natin. So, back again to our slides. So, non-surgical management. We have two non-surgical management. First is the traction device and weights. So, in here, finifix natin yung spine without surgery at gumagamit tayo ng special device to gently pull yung spine natin at makapag-create tayo ng spine ay ng space between the vertebrae. So nakakatulong ito para mabalik yung spine natin sa right position. Ang mga doctors po nagdadagdag sila ng weights based sa patient size at based sa problem ng spine. So, they also check it with x-ray and neurological exam po para ma-sure na naka-align yung ating device. So, sometimes, minumove nila yung neck a bit para makatulong na mabalik sa normal yung spine natin. Second device is the halo device. So, this stabilize yung cervical spine natin by attaching earring sa patient's head natin and rest naman sa chest ng patient natin at i-connect yon in one frame. So, nakakatulong to immobilize yung spine by allowing controlled movement po. Next, please. So, next is for respiratory therapy. So, we use oxygen to maintain the high pressure of arterial oxygen dahil nagkakaroon tayo minsan ng hypoxemia and maaaring magkaroon tayo ng neurological deficit sa ating spinal cord. So, second, endotracheal intubation. So, eto, ginagawa natin to if necessary. So, extreme care is taken to avoid yung flexing or extending ng patient's neck natin, which can result to extension of cervical injury. Next slide, please. So, for nursing management, first, we need to obtain information about the injury. Kailangan natin maintindihan kung paano nangyari, bakit nangyari, at gaano ka-severe yung injury para makapag-provide tayo ng best care sa patient natin. Second is mag-perform tayo ng neurologic assessment. This involve checking yung various nervous system natin through evaluating yung muscle strength, sensation, reflexes, para ma-determine yung extent of nerve damage if nagkaroon man. Third is assessing vital signs with a focus of on respiratory status dahil apart from our standard vital signs, kailangan din natin na i-focus yung patient's breathing dahil kapag nagkaroon ng breathing problems yung patient natin, nagkakaroon siya ng impact sa spinal cord injury sa patient. So, fourth is ongoing monitoring for various abilities. Continuous monitoring is essential po to track the patient's condition over times. This includes yung regularly assessing ng neurologic function natin, ng muscle strength, sensory abilities, and yung mga pattern ng bowel and bladder control. Next is maintaining proper body alignment. So, to prevent complications such as muscle stiffness and pressure sores, it is crucial po na ma-ensure natin yung patient natin, yung patient's body ay correct align. So, next is, kailangan natin i-position si patient on a firm bed with pillows placed strategically under their limbs. So, etong arrangement nito ay naka-design para ma-prevent yung joint stiffness at ma-protect po yung skin ng patient natin from developing yung pressure sores. Next is positioning to prevent contractures and foot drop. So, special care is taken to position the patient to prevent contractures and foot drop, which is a condition kung saan yung foot drops down due to muscle weakness. So, this positioning helps para ma-maintain yung joint flexibility and foot alignment. So, kailangan din natin na i-frequent na position change ang ating patient para ma-promote ng healthy blood circulation at ma-prevent yung skin sores. Next is, kailangan din natin linisin at i-monitor yung device na ginagamit nila such as halo device and yung weights na in-explain ko po kanina. So, we need to observe the signs of trouble such as redness, drainage, or pain. Next slide, please. So, for care of the bladder, so kapag ang patient natin ay nagkaroon ng SCI, yung bladder muscles nila ay hindi nag-work properly, leading to urine retention. So, we use catheter temporarily. So, first is intermittent catheterization. So, catheter is used to empty the bladder at regular intervals. So, it's to prevent the bladder for becoming too full, which can lead to infection. So, by emptying the bladder regularly, the risk of urinary tract infection is reduced. So, second is kailangan natin i-change weekly and magbigay ng medication yung sa change weekly catheter change and medication. So catheter is changed every week and the patient is given preventive medication para ma-fight off yung potential infection. So next slide please. So, immediately after SCI, a paralytic use usually develops as a result ng neurologic paralysis of the bowel. Therefore, yung nasogastric tube natin is often required para ma-relieve yung distension and ma-prevent yung vomiting and aspiration. So, yung bowel activity, usually nagre-return siya within the first week. So, first is medication for bowel care. So, due to their condition, they can move that much so we can give medication for their bowel such as yung laxative, yung stool softeners para ma-prevent yung constipation caused by immobility and pain medication po. Next is the enemas or manual health natin. So we advise the patient na gumamit ng soapy water enema or tulungan natin sila physically para mag-empty ng bladder nila. So, these methods are used to prevent constipation as well and keep bowels working properly. Next slide, please.
So this one, health promotion, mostly is about the primary prevention. So before pa mangyari yung actual na injury. So advise drivers to obey traffic laws, encouraging them responsible driving by obeying traffic laws, avoiding speeding, and refraining from driving under the influence of drugs or alcohol. Seatbelts and shoulder harnesses should be worn by all drivers and passengers, while kids under 12 should use appropriate restraints in the back seat. And caution should be exercised against riding in the back of pickup trucks. Advisable for motorcyclists naman, scooter riders, mga nagbabicycle, skateboards, to wear helmet. And then community-focused programs should be encouraged in preventing violence and suicide. So water safety and fall prevention education also especially for older adults should also be provided. And then yung sa mga athletes natin, for athletes, they should be advised to use protective gears and receive proper training and proper techniques. Next, yung owner of firearms should securely store them to prevent children from accessing them. So yun yung mostly for health promotion lang to prevent spinal cord injuries. Yung mga pinakamadaling pwede nating gawin. Next.
Okay. Kumpleto. Salamat. Balikan mo yan yung last slide. Gusto ko lang mag-react doon. Okay, so itong health promotion, talagang totoo yan. Totoo yung dapat natin gawin. We have to. And it's not only nurses, but it should be a coordination or collaboration with different health agencies sa lugar, kagaya ng Pilipinas. At the same time, hindi lang health agencies, different tawag dito, agencies pa ng government. Okay. Now, yung sinasabi natin na advise drivers to obey traffic laws, it is a must for everyone who is driving. Pero the only thing is that, bakit talaga meron mga driver na barumbado? Meron mga driver na mainitin ang ulo. Meron talagang ganyan, kunting ano lang, ayan, kung ano na ang nangyayari, anong ginagawa, bababa sa sasakyan, ayun, pupunta doon sa isa, ihaharas niya yung isa. Sobrang init, parang siya yung hari ng ano, ewan ko pa paano. So, sa mga bagay na ito, kailangan titignan nila yung ano, titignan nila ang pinaka-root cause. Okay? Kasi hindi natin ma-solve yun pag ganyan-ganyan lang. Okay, now lately, marami tayo mga road rage na sinasabi. Okay? So isa sa mga interventions na ginawa ng LTO for now, na kapag meron mga evidence of road rage, meron na sila mas mabigat na penalty, which is a good thing also. But this will not, will not stop people to tawag dito, to regulate their emotions, the anger. Kasi kailangan, it starts from the people itself, di ba? Yung, kailangan mo yung ano yung mindset mo baguhin, hindi yung kaagad, react kaagad ng violente, mga ganyan. Another thing, itong mga ano sa firearms, may mga tao talaga na kapag may firearms, feeling nila powerful talaga sila. And that is also another thing na what do you call this? Tawag nito, yung hindi natin makontrol, lalo na yung emotion. Kapag nadadala sila sa emotion, sa galit nila, tapos meron silang bagay na para gawin silang mas powerful, takot yung tao sa kanila, gagamitin talaga nila yon. Now, but the only thing that is good here in the Philippines is that we have a very strict rule when obtaining firearms. Hindi tayo basta-basta, pero ganun pa rin, nakakalusot pa din. Unlike in other countries, like particularly in the USA, they can easily buy firearms. Talagang parang ano lang yan, parang pagkain lang yan, parang burger lang yan. Dahil nakikita nyo, marami talaga sila mga youth, mga students, bumibili ng baril, ayun, ginagamit ng baril, minamalasakar ang mga schools, yung mga ganyan. So, napakadali sa kanila. Hopefully, they will learn from it and then maayos na or maging stricto na sila dyan. At saka yung ano, pati sa school, kahit dito nakakatakot din, di ba, kung masyado tayong maluwag sa entry and exit ng mga tawag nito, lalo na yung entry, na dapat talaga proper ang screening bago pumasok sa school. Okay? Otherwise, meron tayong mga sinasabing kasabihan nga about this, yung mga sasakyan and things like that. Mag-iingat nga tayo, pero yung kasalubong natin hindi nag-iingat, ganun pa rin. Okay? So kailangan lang talaga dasal, gabahin, humingi ng gabay at protektahan sa mga ganong-ganong bagay. Okay? What else? Saan ba yung ano? Asia. Yung Asia. Okay. So, ang Asia, meron siyang ano, nasabi ba to ang meaning ng Asia, Ga? Nasabi niyo ang meaning nito? Okay, this tool is developed by the Americans, kaya ang tawag dyan is Asia dahil it is referred to as the American Spinal Injury Assessment. Okay, so assessment daw, association. Assessment, okay. Wala ko association. Kasi tool yan eh. Okay. So, ang ginawa nila yan, this is only to test yung sensory and motor function. Gaano ka-level tindi ng injury. Kaya meron siyang classification. Meron siyang A, B, C, and D. Okay. So, take note, ang letter A or yung scale A or yung sabi nila classification A, dito, wala talagang galaw. Kasi it's more on C1 to C4 ang injury. So walang sensation at walang galaw, walang motor movement. Pero yung B, meron siyang, ano ba yun motor lang ba o sensation, sensory? I think motor ba or sensor, hindi ko maalala. Pero ang C and D, meron siyang sensory, bahagya lang ang motor, and D, walang problema. Ibig sabihin, kapag classified as D, ibig sabihin, based on the assessment tool, walang problema kahit na nagkaroon ng spinal cord injury si patient kasi lahat ay may sensation at may motor activities. So yun lang yung sa Asia. And another thing, isa to sa mga quick assessment to determine, remember your nursing management kanina, ang sinabi nyo na alamin kung ano at saan, ilan, gaano, or whatever ang gravity ng injury, ito yung ginagamit natin. Kasi based on this, malalaman natin ang level ng motor and sensory, what do you call this, deficiencies or disabilities, para at least from there, alam natin paano ang plan of care gagawin. Okay? Then meron tayong, gusto ko lang i-add doon sa mga diagnostics, yung evoke potential. Kasi alam niyo naman, ako noon talaga masyado akong meticulosa. Sabi ko, uy, bago itong procedure. Bago pa lang kasi ako noon doon. Uy, bago itong procedure. Tapos so, sasama ako yan sa patient. Kasi alam ko naman sasama ako sa patient, tapos in-endorse ko yung ibang pasyente ko sa kasamahan kong nurse kasi gusto ko makita kung paano yung procedure. Kaya, ayun, kilala ko siya. Kaya i-share ko lang sa inyo. So itong evoke potential na assessment, it's somewhat like an EEG electrical impulse, ay mga electrodes kinakabit yan sa mga ulo. Okay, sa ulo to monitor the brain impulses or to monitor the brain activity. At the same time, kinakabit din yung electrode sa limbs, sa braso at sa paa. Okay, now this one, they will have to test how much or gaano katagal magta-transmit yung impulse once na-trigger papunta sa brain. So mapapansin nyo kapag meron evoke potential, kaya nga evoke kasi magti-trigger si assessor, yung ituturok niya yung something na magpiprick siya, something doon sa paaba o sa kamay ni patient, and imo-monitor niya yung brain activity. Brain activity, it comes out in a graph. So doon makikita natin kung gaano katagal ang impulse galing sa kamay papunta sa brain. And then kung walang impulse, wala kang ini-initiate na any pain, sensation or whatever, ino-observe yan hanggang sa ma-induce yung sleep. Ano ang mangyayari? Yung ilaw, dim light kasi yan dyan sa loob. Tapos ang ilaw, i-blink-blink niya yan sa mata. Okay, titignan niya rin yung brain activity kung paano ang reaction. So this is particularly sa mga pasyente suspected with any spinal injury, at the same time yung mga spinal infection. Okay? So yun ang gusto ko i-share. And then ano pa ba to? Yung inano ni MacGyver, si MacGyver kasi nag-explain yung pathophysiology. Natuwa lang ako, gusto ko lang i-add yung nakita nyo yung tawag nito, pero wala yata dyan. Tingnan mo nga, MacGyver, yung pathophysiology mo. Yung ano ba tawag nun? Carcaxes ba yun? Ano yun? the ones that are responsible for or participating in the apoptosis of the cells. So properly explained naman ito, pero guys, I do not require you to memorize yung pathophysiology na kasi sobrang masalimuot talaga. Okay, pero natuwa ako doon sa caspases, okay? Yung caspases before the apoptosis happens. Kasi noon pa man, sabi ko, uy, ang galing talaga. Sobrang galing talaga ng ginawa ni God, okay? Alam natin ang apoptosis is a cell suicide, okay? So, itong mga caspase, na-activate yan kapag tawag nito. Pero ewan ko bakit nauna dito ang nauna dito, hindi, ganito kasi yan. Ang caspases, meron kasi yan tatlong klase. Meron siyang initiator, executor, at isa ay yung sa inflammatory response. So ang sa inflammatory response, wala siyang kinalaman sa apoptosis, pero kasabay siya doon sa mga interleukins 1 and 6 and things like that. So doon ang role niya. Hindi ko masyado alam kung anong specific role. Pero nakita mo yung the way that it is arranged kung paano yung mga nangyayari sa katawan natin. Like for example, si initiator kasi, ito yung nag-i-initiate, si caspase initiator, ito yung nag-i-initiate para activate yung apoptosis. Okay? So once na daanan nila yung pathway for apoptosis, mag-a-activate naman si executor caspases. Okay? Si executor, siya na yun papasok. Kunyari, papasok na kayo dito sa papasok na kayo dito sa lungga. Kung ba automatic, voluntary yung mga cells na yung nakaprogram na voluntary, papasok na sila kasi alam nila, yun na ang last nila. Yung mga ganun. Di ba ang galing ng yung arrangement, ang galing talaga ni God. Yun lang gusto ko i-share sa inyo. Okay, sa nursing management, meron lang talaga ako doon sa catheterization. Yung bladder care ba yon? Okay, so bladder care, ang sabi dito, it should be changed weekly. But usually, di ba, sabi natin, kagaya ng, parang na-mention mo rin kanina, di ba, yung there should be an intermittent catheterization. Okay? Pero, hindi na siya masyadong ginagawa or hindi na siya choice of management kasi there is a tendency of the introduction of pathogen to the bladder. So, ang ginagawa is talagang catheterization na lang. And since this is an SCI, then it takes a long time for the patient to recover to be able to have yung atonic bladder niya. It will take time para yung bumalik yung pagkano niya, yung dating condition. Okay? So usually talaga nilalagay natin sila ng catheter. Now, it says here to be changed every week. Again, it is still very inconvenient to the patient to have this catheter changed every week. Usually, it's a Foley's catheter and every week, kahit na sabihin mo, chinecheck pa rin natin yan, chinecheck natin ang lalo na urinary hiatus ng lalaki o ng babae, kung meron bang signs of infection or whatever. And it should be dressed every day with antiseptic, particularly yung povidone with saline. Okay, wag yung pure povidone ha, because the pure povidone can kill the cells as well. Eh lalo na, yung cells niya parang, ano ba yan sa... yung soft tissue cells, yung lining ng vagina tsaka ng urinary hiatus ng lalaki, soft tissue cells yan. Tapos lalagyan mo ng very concentrated kind of povidone. So kailangan naka-mesh, may additional saline solution para hindi masyadong matapak. Okay, now to solve the problem, dahil ito ay matagalan, the patient marami talaga ng mga pasyenteng ito ay naka-silicone catheter. So ano yung silicone catheter? It's somewhat like a Foley's catheter, pero the silicone catheter will last for over a month, at least man lang 1 month. So ang change ng catheter is every month na. Kasi itong mga pasyente na to, kahit uuwi ito sa bahay, naka-catheter pa rin yan. So pinapalitan yan every month. Pabalik sa hospital, pabalik sa clinic, yan, papalitan lang yung catheter, and then balik ulit, and then, gagawa din ng mga ibang evaluation kung ano ng improvement ni patient, okay? So, mas preferred talaga ang siliconized kaysa yung Foley's catheter lang. Kasi kang Foley's, hindi siya magtagal ng more than a week. Kasi nagrurupok-rupok siya. Kasi continuous yung may moist yun eh, di ba? Moist yung sa inside ng urinary meatus, tapos acidic pa yung mga area natin dyan. So, nagre-react si rubber, si latex. So, ang nangyayari, siliconized talaga ang catheter of choice sa mga long period of catheterization, sa mga matagalan na lagay. So, for naman, wala na akong itatanong kasi kumpleto naman. Kayo, may question ba kayo? Uy, may question?
Wala naman po.
Okay. So, ang mangyayari yan, natapos tama po pala yung American Spinal Injury and Impairment Scale, ma'am. Okay, sige, okay. So, association pala, hindi assessment. Akala ko assessment tool yun. Hindi, kasi ginawa ng mga American Spinal Cord Injury Association. Sure ba? Naguguluhan ako. Hindi ko maalala, pero alam ko either assessment or association. Anyway, balik tayo. Lahat ng ito ay lalabas sa exam, okay? Yung topic from mods up to SCI. So, read lang kayo dyan, ang read ng mga laboratory findings, ano pa ba? Laboratory findings, particularly ano ang role ng mga sa WBC, ano ang role ng mga C-reactive protein, D-dimer, ano ang, yung mga ganon, yung mga mga LFTs, electrolytes, and things like that. Pero teka lang, meron ba kayo nabanggit dito? Parang hindi ko narinig. Yung TBI, sa inyo ba yon? Hindi. Yung sa TBI nga pala, traumatic brain injury, parang hindi ko narinig yung about acceleration and deceleration. Meron ba yon? May nabanggit ba kayo? TBI group. Meron ba kayong nabanggit nun? Ano ang ibig sabihin ng acceleration? Ito yung velocity ng force ng injury, kaya depende sa velocity, talagang malalaman natin kung what do you call this? Gaano kalakas yung impact. Kaya talagang nagpa-fracture or na-dislocate or whatever nangyari sa brain. Okay? So meron tayong term na acceleration and deceleration. So this one is ibig sabihin nito kung paano yung velocity. So pag deceleration, ibig sabihin yung object ang bumunggo sa'yo. Okay? Kapag acceleration, ikaw yun ang bumunggo sa object. Okay? So don't forget yan kasi lumabas yan sa exam. Okay? Sa exam question. Pero parang nabanggit nyo ba yan, mga TBIs? Asa na si mga TBI? Wala na dyan? Uy, andyan pa ba kayo? Baka ako lang nagsasalita mag-isa. Tsaka si Yui dyan. Okay, si Rachel lang ang nagsumagot.
Ma'am, sila po ata yung nag-excuse kanina na may appointment po.
Sila ba yon?
Opo.
Okay. Kasi meron yung parang hindi ko narinig yung acceleration and deceleration. But again, don't forget, basahin nyo na lang yan kung, for example, hindi nabanggit. Kasi this is also part ng TBI, kasi malalaman kung gaano kalakas ang impact ng injury. Usually kasi ang TBI is more on vehicular accident. So kaya meron tayong yung description na sinasabing acceleration and deceleration. Okay? So, iyon lang. Meron pa ba? May question? So, ilan items ang exam? It's 100 items. And then, it's more on multiple choice. And then, meron tayong true or false konti. And then, fill in the blanks. Pero yung fill in the blanks, nandun din naman ang choices. Okay? So, ayan. Tapos, meron ako tig pa 5 points na scenario chuchu. Okay? Yung, for example, ang condition niya is ganito. Ano ang pwedeng mangyari sa kanya, ganon. So, analyze niyo yan. So, it's part of your critical thinking process talaga. I-connect. Kasi yun talaga ang gusto kong mangyari sa inyo. Alam niyo mga connection ng lahat ng manifestation at yung nangyayari sa pasyente. Okay? So, iyan lang. Rest tayo kunti. Tapos, mag-NLM tayo kunti lang kasi yung ibang part, isali na natin doon sa finals. Pero tapusin natin yung planning kasi wala pa tayong discussion about budgeting and staffing. Napaka-importante ito sa mga leaders or sa mga chief nurse, sa mga head nurse. Importante ito. So, kailangan idagdag to sa lecture natin. Okay, so rest tayo until 3:40. Okay? Balik kayo ng 3:40. O inom tubig, ihi, ganon, para i-discuss ko yun sa inyo. Konti lang yun. Okay? Yung organizing and other things, di ba planning, organizing. So planning lang muna tayo kasi hindi talaga kaya. Yung controlling and delegating sa finals na yun. Okay? So continue natin yung planning. Naalala niyo ba yung guys? Di ba na-stop tayo sa stopping models? Naalala niyo ba yon?
Yes po, ma'am.
Okay, so yun na lang. Ang i-discuss ko ngayon ang staffing and budgeting. And then we will stop there. Tapos yan ang sasali doon sa sa mga exam natin. Pero yung organizing, delegating, and controlling sa finals na lang dahil hindi na talaga kaya, mahaba-haba din kasi yun. Pero importante din naman talaga yun sa inyo. Okay, Dok? So balik tayo ng 3:40. Saglit lang naman yun.